welcoming one of our new members. So welcome everybody to our guests who are joining us, to the ARC staff, and most importantly, to our NAC members. The NAC, the National Advisory Council, is ARC's legal opportunity to get full and honest feedback about what is happening in the field and how ARC can direct its priorities to have the most impact to improve the quality, the safety, the equity, and the value of America's healthcare system. So to all of our NAC members, thank you for being representatives of the American people and for helping ARC steer its work. I want to thank the team at ARC who has put this meeting together, led by Jamie Zimmerman and supported by Karen Brooks and Amy Rabin, who our NAC members know well. Without them, we wouldn't be able to have had all these virtual meetings this year. So thank you all in advance for setting us up for success today. As the acting ARC director, it is my pleasure today mostly to listen, to hear from the NAC members about what is happening in their worlds and how they would like ARC to move forward. In order to do that, we needed to have somebody to lead the meeting. And it was a pleasure as one of my first official acts as the acting director of the agency to appoint a new chair to the NAC. So I'd like to introduce to all of you somebody who many of the NAC members know, but the public may not, Edmondo Robinson. Dr. Robinson is serves as the Senior Vice President and Chief Digital Innovation Officer at the Moffitt Cancer Center. He is responsible for leveraging the tools of information technology, health data services, and digital care in order to expand the Cancer Center's ecosystem to deliver consumer-oriented, real-world solutions in clinical practice, in research, in education, and in administration, all areas that are important to ARC as we move forward together. He's also an associate professor at the University of South Florida's Marcenari College of Medicine and an adjunct senior fellow at the Leonard Davis Institute for Health Economics at the University of Pennsylvania. He received his medical degree from UCLA, an MBA from the Wharton School, and a master's degree in health policy research from the University of Pennsylvania. So Dr. Robinson, it's my pleasure to turn this meeting over to you.
Thank you very much. Really appreciate that, David. I think with that, we can move forward with calling the meeting to order. And so we'll do so. I want to, thank you, David, for that kind introduction, and welcome all the NAC members as well, participants and guests to this meeting, as well as, of course, all of the ARC staff. At this point, I think we'll go ahead and jump into a roll call, make sure we have our NAC members on board. So I'm just going to run through the names and go ahead and just pop off of mute and say present here as I go through each of the names in alphabetical order. So starting with Greg Alexander.
Good morning, I'm here.
Asaf Bidden. Gretchen
late. Sorry, Edmondo. He's joining a little bit later. He had a quick meeting.
No problem. Gretchen Dolan.
Yep, I'm here. Good morning.
Thanks. Susan Edmund Leviton.
I'm here. Good morning.
Peter Emby.
Present. Good morning.
Chris Gasho.
Here.
Omar Latif. And we'll hold on that. My fam.
Here.
Ram Raju.
I am here, and congratulations, Mr. Chairman and the acting director.
Thanks. Patrick Romano. And Yangling Yu.
Morning, I'm here.
And then on ex officio side, I think we had for David Eakins, I think we have Naomi Tomoyasu.
Yes, here. Thank you.
Thank you. Sherry Ling.
And it's Lee Fleischer who.
And Lee Fleischer. Awesome. So we got both of you.
I have to hop off intermittently, so Shari will be here most of the time. Thank you.
Understood. Thanks, Lee. And I'm not sure if Ileana Arias was able to make it.
I am. Good morning.
Awesome. Thanks for being here. So that, I believe, is the roll call. So just a reminder for everyone to note that this meeting is being recorded. It will be posted on our website once it's available. And note that there is closed captioning available for the meeting. If you need that closed captioning, please click the icon at the bottom of your screen. For the ARC staff, Patrick Romano is noting that he is here as well. For the NAC members, just make sure to, if you have a comment or you want to ask a question, you can go ahead and put that in the chat box. It comes to all the panelists, and then we can go through that, and then make sure that you go ahead and unmute yourself when it's time to speak. Otherwise, keep yourselves on mute, and then the meeting will go nice and smoothly that way. Also, just from a Zoom management perspective, you may want to change your video settings so that you can actually see each other and be on video, and also kind of see the presentation. So there's a side-by-side option that you can do there. So that may be the best way to do it. And again, managing Zoom in this new world here. Any non-NAC members who want to make a public comment for the meeting, please send an email no later than 12 noon Eastern time to National Advisory Council at ahrq.hhs.gov. Again, National Advisory Council at ahrq.hhs.gov. And then your comments should be limited to 3 minutes each. Okay, so I think that's the kind of the housekeeping here as we get the meeting launched. So first order of business, the NAC members should have received minutes from our November meeting. I hope you all had a chance to review those minutes. At this time, I'll ask for any changes or edits to those draft minutes from the November 10th, 2020 meeting. Hearing none, do I hear a motion to approve those minutes?
It's so moved, Chairman.
In a second, I see Dr. MB seconded.
Second.
Okay, so we will go ahead and approve those minutes as motioned and seconded. All right, so that's our kind of our first order of business. Let's launch into the rest of the agenda. We're making good time. Appreciate everyone on that. So let's start off with an update on our recent accomplishments. So we'll hear about health system research from Jeff Brady, who's the director of ARC Center for Quality Improvement and Patient Safety. Then after that, we'll hear about practice improvement from Arlene Bierman, who's ARC's director for the Center for Evidence and Practice Improvement. And then we'll round it out hearing about data and analytics from ARC's director for the Center for Financing Access and Cost Trends. So why don't we go ahead and launch that? I think we're starting with Jeff.
So good morning, everybody. Just a quick check. Can you hear me okay?
Yep.
Perfect. I appreciate that. It's my pleasure to be with you virtually here today. And as you heard, I'm going to go over ARC's recent accomplishments in the category of health systems research. Could I get the next slide, please? So I think it's no surprise to everybody listening that the agency and our sort of extended stakeholder group, grantees, contractors, et cetera, have been focused on COVID since the pandemic began. And so to that end, I'm pleased to report that we've awarded some 28 research grants totaling approximately $17 million to explore some essential questions about the delivery of healthcare during the pandemic. Just a few examples of the areas of focus for these projects include telehealth. I'm sure no surprise to you all. The best practices related to COVID care, in particular in rural healthcare settings, emergency management in hospitals, obviously an important topic, and critical barriers to effective pandemic response in hospitals that care for vulnerable populations. So I'm pleased to see that equity focus is well represented among these grants. You can find more information. You'll notice that there's a hyperlink on the slide, and that will take you to an agency website that gives a summary of each of the grants. And then there's also a further link to the NIH reporter. So really excited about that work. It's again, hopefully no surprise to you, but I think it represents an incredible collection of effort that is contributing to solutions. Next slide, please. As much as we'd like to hope that one public health crisis would displace another, that unfortunately has not been the case with COVID and substance use disorder. And so that is really the main impetus for the release of the special emphasis notice that focuses on this topic in particular. So just to build out a little bit more, the reasons that the agency put this out, we still see drug overdose deaths and morbidity from substance use disorder. Those are not decreasing. In fact, they're actually increasing. We further observe, all of us, that polysubstance and stimulant use is also increasing. And most importantly, the root causes of these problems have not been addressed. So to that end, some of the priorities that are described in this special emphasis notice are focused on dissemination and implementation of things that have worked, evidence-based practices, heavy focus on non-pharmacological and behavioral therapies, especially those that address, again, polysubstance abuse. We, with this emphasis notice, wanted to underscore the importance of context and with treatment considerations that relate to social, environmental, and psychological factors, as well as economic factors, obviously a big component of the effects of the pandemic. And then finally, just the overall focus on understanding how this problem affects other chronic conditions. I think this is definitely in keeping with the agency's systemic, kind of broad-based view of problems and relationships to other ongoing efforts, and ultimately supporting this perspective on whole person health. Next slide, please. And that prior work, which focuses heavily on disparities, the focus on substance use disorder, I think also aligns with this work in terms of the agency's commitment to promoting health equity and addressing some of the underlying problems. So this is a request for information that the agency has out now. You'll see public comment is open and ends on May 4th. And it's a focus on the use of race and ethnicity in clinical algorithms, and how those actually may lead to worse outcomes for Black patients in particular. And there's a lot of interest in the field from the public, from researchers, about how this issue plays out and ultimately affects Black patients. Some of the particular areas of focus from a clinical perspective, nephrology, cardiology, obstetrics, and urology, where unfortunately the potential and actuality of these sort of reflection of race, ethnicity in an inappropriate way is again affecting care. And so we had a letter from Congress back in September, and it focused on an interest in an evidence review around this topic. And so this is an important part of our approach and stakeholder outreach to try to, again, advance the field and get a handle on what exactly is happening through an evidence review. So we're hopeful about how this will be an important contribution, again, to decreasing disparities and addressing this important problem. Next slide, please. So on a slightly different note, this is important work that the agency has been sort of pursuing for quite some time now. And this particular update, this is focused on our comparative health.
All right, brother, I got another call. I'll catch up with you soon.
Oops, sorry about that. this is focused on the Comparative Health System Performance Initiative that, again, the agency's been working on for some time. In December, I'm pleased to report there was a special issue of Health Services Research that was an outgrowth of this work. There are some 10 journal articles that are in this supplement. I think it's particularly notable that 2 commentaries, one by former ARC Director Rick Cronick and then another by David Blumenthal, address issues including the unrealized potential of health systems, focusing on improving quality, and in particular the need for further incentives and policy changes to realize the full benefits of integrating care within health systems. So this is a really exciting development. You see 2 other works focused on perceptions around care integration and how that compares both within and outside of health system boundaries, as well as, again, I think another example of the agency's commitment to eliminating healthcare disparities, another piece within the supplement that's focused on healthcare disparities and with clinicians who are either affiliated or not affiliated with different physician organizations. So please take a look at that when you can. And the last item that I'd like to update you about, next slide please, is some important research findings. Could I get the next slide please? Thank you. So is just a quick summary of some important research findings, which actually I think definitely are, this is impactful research, but I'm also happy to report that I think it has the really important potential to impact practice. So this sort of maybe has a foot in our practice improvement work as well. And these are results from an acute care cohort of the ARC safety program for improving antibiotic use. And it was published in JAMA.
I apologize. It's my first full NAC meeting. I'm not sure whether we're supposed to interrupt you with questions or wait till the end.
That's a great question. Let me ask Jamie or David.
So we're going to wait till the end after
Okay.
David presents. So if you can keep that question, we would love to hear that after David presents.
Thank you for that. Appreciate that.
That's my
So again, these results were published in JAMA Open just late last month in February. And it's the antibiotic use in the program was reduced in over 400 hospitals by 30.3 days of therapy per 1,000 patient days over the 1-year period. Another important finding that you see there is some reduction in Clostridium difficile rates, which were also reduced by 19.5%. Now, even though the way this project was designed, there was not a control group, the team that conducted the project did analyze hospitals of similar size distribution in the Premier Healthcare database, and they found no reduction in that comparison group in antibiotic use over the same period. So these are pretty notable findings. And the reductions found in the project were achieved despite 43% of hospitals not having access to infectious disease specialists at the beginning of the program. And 21% of the hospitals were also classified as critical access hospitals. So that finding really says to us that the improvements in antibiotic use that were demonstrated here can be achieved using the program even in under-resourced hospitals. This is built on a successful kind of improvement platform that we've used in the agency for some time, the Comprehensive Unit-Based Safety Program that you've heard a lot about over the years, and we continue to adapt that approach to different problems, and this is a recent example of the success we're seeing with that. So appreciate your attention and look forward to questions, as we said, at the end. So I'll turn it over to, I think, Arlene, which is who's next. Thank you.
Good morning. I'm going to give you some brief highlights of the work we're doing in practice improvement. And next slide, please. So the first initiative I'm going to talk about is our National Nursing Home COVID Action Network. And this was launched in the fall of 2020 with an investment of $237 million from the Provider Relief Fund to establish the network. And we've partnered with the University of New Mexico's ECHO Institute and the Institute for Healthcare Improvement establishing a network of over 100 training centers that provide training to approximately 9,000 nursing homes in all 50 states and Puerto Rico. And this is based on the ECHO model, which I'm sure many of you are familiar with, and was developed initially with ARC funding many years ago. So each week, the network conducts over 300 training sessions that use case-based learning to allow peer-to-peer mentoring, along with expert practice facilitation. And on the right-hand side of the slide, you can see the 6 goals for the network, which range from infection control to addressing social isolation in nursing home residents. Next slide. So the other thing that this network is doing is developing resources and tools, not only for the participants in the learning networks, but that will be more widely available publicly. So ARC is contracted with NORC at the University of Chicago to be the coordinating center. And the primary goals of the coordinating center are to disseminate lessons learned from the network and to develop new tools and resources on nursing home safety and quality improvement to address gap areas. So we recently released an online resource catalog. This is a new resource, and the catalog is designed to share resources and tools with nursing homes and other stakeholders who have not been participating in the network. And it will be, continually refined and updated as new. You all know that the evidence for COVID and managing it is moving very quickly. So we're going to aim to really keep these resources current. The catalog features a new resource developed by Project ECHO and IHI to help nursing home administrators to address immediate staffing shortages. It outlines short and longer term steps to reduce staff shortages, particularly shortages of direct care workers. And this month, the Coordinating Center will release new resources addressing vaccine competence. And a learning guide will provide nursing home facility leadership with strategies that enable them to have effective one-on-one conversations with staff on vaccines. And the guide outlines a standardized strategy for delivering an organized curriculum to help staff raise staff awareness of accurate information about COVID-19 vaccines. We all know, the tragedy of all the misinformation that is out there. And the learning guide will be accompanied by 8 videos that specifically target certified nurse assistants. And additional resources that target timely and urgent issues are in development. And we are currently focusing on developing resources to address PPE usage and visitation in a post-vaccine environment and considerations for managing long-haul COVID. And we really welcome your input and suggestions on this initiative and what tools and resources would be most welcome. And we're excited as an agency to be involved in really help improve care for this during this crisis in this really important sector that has been disproportionately impacted by COVID. Next slide. So now some of our patient safety work around practice improvement. And so the recently has issued 2 briefs around diagnostic safety and quality. And you all know that diagnostic safety is a major priority for the agency. And the first one is evidence on the use of clinical reasoning checklists for diagnostic error reduction. So people have identified this as a potential promising approach. And what the review found was, there's some mixed results in the literature and it's not ready for prime time yet, and gave guidance for what research we need to make this, to understand the role of checklists in reducing diagnostic errors. And the other one looked at a range of health information technology on engaging patients in the emergency rooms for, making diagnostic decisions, and, including patient portals, mobile technology, shared decision-making. And I'd really encourage you to look at these briefs they're available online. Next slide. So we're mandated to do a report to Congress on strategies to improve patient safety. And the final report is due to Congress in December 2021. And the draft report is available now, and it's actually available for public comment. So we would welcome your input on this, and somebody could share probably the link for public comment in the chat. But the report addresses effective strategies for reducing medical errors and increasing patient safety, and also measures determining appropriate to encourage the appropriate use of such strategies. Next slide. So now I'm going to tell you about our dissemination and implementation portfolio, which is really growing and having, I think, an important impact. And the way we approach our dissemination and implementation is really integrating quality improvement and implementation science. We all know we've been trying to improve care delivery for many, many years and would like to see a bigger impact. And we feel by implementing but studying what works while we're implementing, we could both improve care and advance the science at the same time. I know all of you who've been on the NAC for a while are very familiar with Evidence Now, which focused on cardiovascular risk reduction in small and medium-sized primary care practices. And we're continuing, the final results of this initiative are coming out. It really focused on practice facilitation and use of health information technology to improve care, among other things. And we're continuing to release the results and the learnings from this initiative, as well as tools. And a new tool that was recently released is the practice recruitment and retention toolkit that's available online. We have a series of other initiatives around implementation in primary care. One of them that was launched last year and has been affected by the pandemic is our Evidence Now is Managing Unhealthy Alcohol Use initiative, also targeting primary care and targeting two ARC reports. One is the task force guidance on screening and brief intervention in primary care. And the other was an evidence report by our EPC centers on medication management in primary care of alcohol use. And it aims to increase the uptake of evidence-based interventions in primary care to screen for unhealthy alcohol use, offer brief interventions to those who screen positive, and to offer referral and treatment to those with alcohol use disorder. And the goal is to engage 750 primary care practices in implementing these interventions, and also to really, it's about integrating behavioral health in primary care, and what can we also learn about models to do that. And we also know that increased alcohol consumption during COVID-19 pandemic raises the need for screening, brief intervention, and referral treatment services in primary care, and it heightens the value for practice D&I during COVID. And the grantees are learning from each other about recruitment in this context, and we'll be featuring these lessons. There's actually a webinar next week on what this project has been doing. So if you're interested, we encourage you to participate. And then we've also compiled tools and resources for managing unhealthy alcohol use in primary care, intended for use by providers, organizational leaders, and other team members, and have added information on telehealth. I think this was also an example of ARC being able to pivot. People had designed their interventions before COVID, and we've been able to sustain this during the COVID pandemic. The other one is Take Heart, which is focused on scaling and spreading cardiac rehabilitation. And this is really a national initiative. The American Hospital Association is involved. And we know that cardiac rehab is underused, that it reduces mortality and morbidity after a cardiac event. We also know there's huge disparities in who gets cardiac rehab and who doesn't. And during the pandemic, hospitals scaled back on cardiac rehab on site and remotely supported cardiac rehab patients in their homes, and developed hybrid on-site and home-based interventions. In response, Take Heart postponed what it had been initially planning, and has been working with hospitals around the country who've been sharing information on how they continue to deliver cardiac rehab in this environment. And just on this slide also is another toolkit from Evidence Now about recruitment and retention of primary care practices. And one thing that isn't on the slide is we have a funding announcement on the street now on managing urinary incontinence in women. And those applications are due next week. And each of our implementation projects has a theme, as you've seen: behavioral health, scaling and spreading. This one is really going to focus on integrating primary care with the rest of the health system and the community in terms of managing this condition. Next slide. We're very excited about this new Evidence Now initiative that builds on our first one on advancing heart health, on building state capacity. So this is a 3-year, $18 million grant initiative to help primary care practices in states with the highest rates of preventable cardiovascular disease events to advance equity in heart health. And there's 4 state-based teams. We targeted states with the highest in the highest quartile of bad cardiovascular outcomes, avoidable events, as well as limited capacity to do primary care transformation. And these state-based cooperatives will form cooperatives to expand practices' ability to use evidence and to improve care, including linkages to public health and community services. So we really think the focus of these are going to be on tobacco cessation and hypertension control, which has gotten a lot of attention recently. It's worsened nationally over the last few years, whereas actually improved in the Evidence Now intervention practices. So, we think to get more impact in terms of, improving cardiovascular health and reducing risk, we really need to link public health and primary care efforts. And we've had great conversations with the CDC for how we can, share information and align efforts in these states. And just to finish on this slide is, this is really an example that we're really committed. AHRQ is a lead federal agency for primary care research. And so, we really want to understand and engage primary care practices in improvement and really understand what it takes to make, the primary care really what it should be as the foundational part of our health system. Next slide. So this is my last slide. And I'm going to talk about one aspect of our digital health work is our clinical decision support work. And this is mandated actually under the Affordable Care Act through the PCOR Trust Fund. And so we actually have some really exciting work in progress on this. So we're mandated to advance patient-centered outcomes research evidence into practice through computer-based clinical decision support, and to make clinical decision support more shareable, interoperable, and publicly available. And you're all familiar with CDS Connect, which we've presented to you before. I'll give you a little update on that. But we've recently embarked on a new initiative called CEDAR, which is CEPI, Evidence, Discovery, and Retrieval. And it's a 2-year contract with MITRE. And CEDAR aims to make it easier for other platforms to be able to find and use AHRQ resources. So AHRQ has a wealth of resources and tools, but we know that, coming to our website, it's hard to find them. So, really for us internally to use digital technology to develop strategies to make it easier for everybody to find our research resources. And basically, we're going to develop, APIs or application programming interfaces. And so this relies, it'll just make our resources more fair and useful. And we're very excited about this. And then we presented to you previously to the NAC about our CDS Connect, which has been quite successful in developing a platform to share, the artifacts for clinical decision support and think about long-term sustainability. And so ultimately, we would like to develop a public private partnership. So this could be sustained in perpetuity. And we're currently deliberating. We're taking a phased approach to explore the feasibility to do this and gather public input and decide how to make forward on a sustainable model for CDS Connect. And then, within CDS Connect, you've seen our pain management dashboard, which I've presented, previously. And we have 2 projects that are building on that right now to really advance the usefulness of our clinical decision support. And one interesting project by MedStar is focusing on helping clinicians and patients implement a taper plan for opioids. For those of you who are new, I should probably say the pain management dashboard brings together data from the EHR, so it'll have a history of medications used for pain management, diagnoses, experience of the patient. So it really makes it easier to, risk factors to track and manage opioid use and pain management in patients in practice. And then we have another CDS related initiative through ARC's evidence-based care transformation support, or ACTS initiatives. And in this, we've actually developed a lot of work around COVID-19. I think COVID-19 has given us examples about how fast the evidence is moving and changing, and how do you provide the most current evidence to people in practice. And we have a number of pilot projects under that for how to really share, clinical decision support around COVID, how to implement it, and how to keep it up to date. And then finally, I want to highlight a funding opportunity that we have, calling for R18 grants to demonstrate and disseminate shareable, interoperable clinical decision support. And we hope you can help us share this announcement with your network so that we can continue to receive the best applications in this really exciting area. And I'm going to mention one more funding announcement. We recently released a program announcement for R21/33 entitled Using Innovative Digital Healthcare Solutions to Improve Quality at the Point of Care. And so I think you're all familiar with R21's developmental awards, and by combining it with an R33, it will let us actually, for those who are successful, have a pathway to further funding to follow on the first grant. So I'm going to stop there, and thank you.
I guess I'll just pick it up here, if that's okay. My name is Joel Cohen. I'm the director of the Center for Financing, Access, and Cost Trends. And I'm going to talk a little bit about the recent accomplishments in data and analysis from the agency. So next slide, please. What I want to do is talk a little bit about some of our data initiatives, and then get into some of the recent research that we've done that is of interest, some of which is related to COVID, some of which other issues, but which are sort of at the forefront of what people are asking about in terms of health policy. So the first initiative that I'd like to talk about is a new synthetic healthcare database. Over the last few years, the agency has really taken it upon itself to expand our data resources as much as possible. And we were looking for new areas to sort of supplement our core databases and data projects like the HCUP and the MEPS. And one of the areas that we wanted to get into was, having more detailed data on claims and the use of services by individuals. At the same time, the administration was interested, and there was an executive order looking at creating these synthetic databases which had more detail. Now, what is a synthetic database? It's really database that's created that is a response to two different objectives in healthcare and privacy that the country has. You know, number one is there's a lot of focus on making data more available. You know, we need more information. We need more detailed information. We need to know exactly what's going on with people. On the other hand, there's a lot of concern that private information is getting out. And that you can identify individuals and identify characteristics of individuals that you really don't want out there in the public domain. So what you need to do is develop some way of putting together you know, actual data and representative data in a way that provides you with the detail that you need, but does not allow you to identify any individual, even though you have very detailed information on individuals. So synthetic data is a way of doing this by putting together nationally representative survey data with very detailed claims data and introducing perturbations in the data so that you can't then tie any individual record back to a person so that they can't be identified. So this is really useful for looking at, for example, rare diseases or specific treatment patterns, or if you're trying to look at what's happening in local areas. Once you start you know, focusing in on particular areas with people with particular problems, if you don't do some of this anonymization, it's easy to identify folks, and you don't want to be able to do that. At the same time, you want to have all of the characteristics represented appropriately across individuals so that when you're doing research, it's really representative of what's going on. So this synthetic database that we are creating is an attempt to do this, and it pulls together information from public programs and private programs, combines that with our national survey data from the MEPS. And so what we'll come up with is a nationally representative database that then has a lot of detail that you don't otherwise get in the survey data. So we are in the process of pulling that together. We have an internal file that we are looking at the moment, and we are putting together a public use file, which is right now scheduled to be released next month. You know, watch the website and you can see this come out. But we think this will be really useful for looking at some of the issues that right now it's not possible to look at with the data that we have. Next slide, please. Another of our initiatives is relates to social determinants of health. And of course, particularly recently, there's been a lot of recognition that that what happens in the physician's office or the hospital, or you know, a health provider contact, is not really the main determinant of an individual's health. It's an important one and has some impact, but really what has more of an impact is people's social circumstances and you know, their own behaviors and the circumstances, the environment that they live in. So, you know, when you're looking at the healthcare system and you're looking at the impact of healthcare providers and services on the population, you really need to take into account these social determinants, because those are going to have a big impact on what's going on. If you don't account for those, you risk not really being able to tell what the impact of different interventions in the system are. So there are a lot of folks who are talking about this, and there's a lot of sort of data out there in various places. Interestingly, there is very little information, or there is no particular database which is you know, consistent and easily accessible and easily linked to other data. So, you know, typically people, when they're doing their research projects, they'll go out to Census or other places, or, you know, the Area Health Resources file or the AMA or the AHA or whatever, and try to pull their own data together. So this project actually started as an internal project because as I said, we have, some core databases, in my center, HCUP and MEPS, and we were looking for ways to be able to pull these data together for our own research purposes. So we started this project to create our own social determinants of health database. As we were doing this, there was a lot of interest outside of our agency in this as well. And we ended up getting money from the PCOR Trust Fund to expand and go into more depth in this project. So we actually are in the process of doing that. We started with our own. We're in the middle of this right now, but we have a beta database that we pulled together, and basically it looked at publicly available data from around the country, looked across the different domains of social, economic, financial, healthcare, et cetera, to see what we could pull together in a consistent and well-documented way with a link variable that would allow you to easily link the data to whatever database that you have. So we have pulled together this beta database. We put it out there. It's got links at the county and the zip code level. And we're actually asking folks, as you can tell from the slide there, help test our new SDOH beta database. So we're asking folks to look at it, to link it to their own data, to use it in any way they can, and then get back to us with information. We're interested in their responses and their input in ways that they think it could be improved or where we have gaps, et cetera. So we're soliciting public input on that database. Then we'll feed that back into the project as we develop the more comprehensive database in the future. So right now, as I said, we just put out the beta database. We've had some conversations with folks in various places. Patricia Keenan, who is in charge of this project from our center, actually did a seminar in the department last week. It had a tremendous amount of interest. There were like 140 participants. I guess it was a record for this ASPE seminar that they did. So there's a lot of interest in it, and we'll continue to work on it. And if the NAC members have a chance to look at it and give us some input, we would really appreciate that as well. Next slide. Okay, so now I'm going to turn to some of the data and data analysis that we've done more recently. And this is from a statistical brief that Pam Owens and my center put together. And it's looking at COVID-related hospitalizations in 9 states. Now, typically the annual files that we put together on HCUP are at least, they're basically a couple of years old, because by the time you can get the annual data together and build the files, et cetera, it takes a little bit of time. So the data aren't as current as you would actually like them to be. But in some cases, some of the states actually collect their data on a quarterly basis, and they will report that to us on a quarterly basis. So again, we got some money from the PCOR Trust Fund to actually process the quarterly data. And so we had been processing it, and it turned out that, this was particularly useful because in the COVID, when the pandemic came around, people were interested in what was going on, but, the annual databases weren't going to be ready for a while. But in this case, we were able to process the quarterly data and look at some hospital statistics during the time period when COVID was becoming a problem. So this is data from April, May, and June of 2020, and we were actually able to put these data out in a set of tables that are available on our website by the end of 2020. So we were able to get 2020 data out in 2020. And this statistical brief is basically based on the information from that table. It looks at COVID-related hospitalizations. This is from 9 states in April through June of 2020. And what the graph shows is the different racial and ethnic groups on the bottom. And then the gray bar is actually from April of 2019. So it's a baseline. And that's a baseline of all hospitalizations, not COVID didn't really exist at that time. So, as a comparison, it's all hospitalizations and shows the distribution. So if you follow the gray bar across the different racial and ethnic groups, you can see what the distribution of hospitalizations were in 2019. Then the other bars, the blue, green, and purple, are April, May, and June of 2020. So this is actually at the beginning of the pandemic. And what you can see is, although whites were very large, they're about 2/3 of all hospitalizations in 2019, you can see that they're much lower proportions of the COVID-19 hospitalizations in these across April, May, and June, and that the minority populations, which are lower proportions of all hospitalizations, are higher proportions of COVID hospitalizations. So it's basically empirical evidence of what people are saying, which is that COVID is actually affecting minority populations disproportionately. Next slide. Just one more point there. Pam, we actually have data from the third quarter now, and Pam is going to be updating that with both the tables and some additional stat briefs in the near future here. So, okay, the National Healthcare Quality and Disparities report. This is actually something that was in the authorizing, it was mandated by Congress in the authorizing legislation for the agency. So when AHRQ was created, this report was mandated in that. And originally it was actually two separate reports. There was a quality report and a disparities report. It turned out there was a lot of commonality across what you're looking at, whether it has to do with patient safety or disparities. So the report was put together a few years ago, but this is the 17th version of this report, and looked at healthcare quality through 2018. And then also looked at disparities over that same period of time. It has more than 250 measures of process, outcome, and safety that it looks at. And basically, it allows you to get an overall sense of where the country is going in terms of quality of care and disparities, and then looks at particular areas and particular settings and domains of care to tell us where we are having problems, where things are going well, where things aren't going well. And so you have some information on, where we need to focus more and where we are doing well at the moment. So, and typically this report is, what happens is there are some areas where we're doing well, some areas we aren't doing well. That kind of varies, but, certainly in terms of like vulnerable populations and the poor and uninsured, there's a lot of work to be done in the healthcare system. So this is sort of telling us, where that is and what we need to work on. Based on the information that they pulled together for this report, they also do different chart books, and there was a patient safety chart book that was updated. There's different versions of it, but it was updated just last month. There are also chart books for veterans. There's some planned for rural healthcare, et cetera. So different topics, they'll pull out the information into specific areas and then have these chart books. And again, these are all available on the agency's website. So you can look under the Healthcare Quality and Disparities Report and get all of this information. Next slide. This is from an article that was done by Sam Zuvikas and some of his colleagues, one of whom is at the CBO, the other one is at ASPE, both of whom were came from SAMHSA originally, so they had a lot of experience in mental health. And Sam is really our center's mental health expert as well. Certainly access to mental health care is important. And an issue that that people are concerned about, and one element of access to mental health care is insurance coverage. So with the recent expansions of the Affordable Care Act and insurance coverage for individuals, there's some research that shows that people with mental health issues are actually more likely to sign up for insurance programs than other folks. So this was kind of looking at the impact of the ACA expansions of insurance on eligibility, Medicaid eligibility for adults, and then focusing specifically on eligibility for persons with serious psychological distress or depression as measured in the medical expenditure panel survey. So what you can see, the top is the full population, and basically they looked at, you know, within the expanded eligibility, what participation in the program was for individuals who were eligible or would have been eligible had their state expanded Medicaid. And what you can see is from the expansions were basically in 2014 for the most part. And you can see that there was definitely increased participation after 2014, particularly the brown line at the yellow line at the top is the Medicaid expansion states. And you can see that the participation particularly increased there. And on the top frame is all individuals. The bottom one is individuals with serious psychological distress or depression. And as you can see, the increase was even greater among those folks. So clearly there was an impact of insurance coverage with these expansions that allowed, you know, persons with mental health issues to have better access to health insurance. Next slide. So this was a statistical brief that came out very recently, last December, looking at the concentration of expenditures. And this is something that, you know, is historically we've looked at using the medical expenditure panel survey. Starting in like 1977. So it was one of the first, you know, looks at the concentration of expenditures to show that basically it's a small proportion of the population that accounts for most medical expenditures. So this has been very, as I said, we started looking at this in 1977. It's been very consistent over that, you know, 50-year period. So this is a concentration curve that looks at the expenditures. And the way you create this is you take, you rank everyone by their healthcare, everyone in the population by their healthcare expenditures. So the most expensive person is at the top, and then the least expensive is at the bottom. And then you count through the proportions of the population, and at the different, you know, percentiles of the population, you can look at what the total sum of healthcare expenditures for that group has been. So if you look at the vertical line that goes from 0 to 100, you know, that's the straight line going up through the center. If everything was proportional, that's what it would look like. You know, everything would be on that line. As you can see, that's not the case. You know, basically it's a very skewed distribution with folks, a very small proportion of folks on the very right side accounting for a huge proportion of expenditures. So you've got this inclining curve as you go out the population, the cumulative population, the expenditures go up precipitously. So if you follow the curve over, you can see that if you go at the bottom, if you look at 50, you'll see that the point there is 3.2. So what that tells us is that 50% or half of the American population accounts for 3% of all medical expenditures. If you go from the other end and you look at 99, you'll see that, so if you go in from between 99 and 100, that's 1% of the population. And that 1% is accounting for 20% of all expenditures. So clearly, you know, there's a very skewed distribution. There's a small proportion. And if you look at 80, you can see what people talk about 80-20, it's right there. It's 80, 19.3. So that's the 80. So 80, you know, 20% of the population accounts for, you know, 80% of expenditure. So in any case, you can see that there's a very skewed distribution. And this is basically focused, you know, attention on in terms of cost control with those folks and what their characteristics are and what you might be able to do to control expenditures or provide them with care that maybe will prevent some of this happening in the future. So it's focused on preventive care on people with multiple chronic conditions, because those tend to be folks or certain types of chronic conditions, and focused attention on care for those types of individuals to try to get a handle on some of the medical spending. Next slide, please. So this is another statistical brief from Bill Carroll and some colleagues in the center who are looking at out-of-pocket prescription drug spending. And this is by type of insurance, but basically this is again an issue that's in the news a lot, and certainly there are some drugs that are extremely expensive and are costing people a lot of money to procure and creating financial difficulties for those folks. But what this is looking at is out-of-pocket spending for the whole population. And basically what it shows is that this looks at different percentiles of the distribution. The median, with the 50th percentile, would be half of the people. So basically, if you look there, and it looks at it over time from those out-of-pocket costs from 2009 and 2018. And basically what you can see is that if you can see it most clearly if you look at the 95th percentile, which are people with very high expenditures, but you can see over that time period for private and public covered individuals that their out-of-pocket costs are actually declining. And that's true across all of these percentage distributions for those populations. That's for the private and publicly insured. However, for the uninsured, you can see that that's not the case, that essentially the uninsured, their out-of-pocket costs are not declining. They're high and not going down. So clearly, folks with insurance coverage are getting the advantage of on average, having lower out-of-pocket costs for drugs over this period of time. And I believe that's my last slide. So that's just some, highlights of some of the work that we're doing in terms of data and research in the agency.
So thank you, Jeff. Thank you, Arlene, and thank you, Joel. I hope everybody can see what an incredible team we have, and also that I hope this expanded, once again, NAC members' ideas about the breadth as well as the depth of the work ARC does. And Mondo, I think I'd like to cede some of my time now to allow the NAC members to ask questions of our three panelists about this work, and then I'll try to keep mine shorter to get us back on time. Would that work for you?
I appreciate that, David. So yeah, I did see a couple of questions. I know Maya had a question. Susan put one in the chat. So questions for Jeff or Arlene or Joel over the last few presentations. We'll take a few minutes for questions.
Armando, did you just want us to jump in? I didn't know if you wanted to call on
Yeah,
people.
why don't we go? Why don't we? Good point. Why don't we start? I think Maya, you were first. So why don't you start with your question?
Thanks. So thank you for not just the presentation, but for all of that tremendous work. I wanted to just understand a little bit better the work on the comparisons of health systems versus non-health systems. If I think if I read it right or heard it right, that there seem to be some high-level takeaways about advantages of better care integration within health systems and at least no harm done with respect to disparities within health systems versus outside of health systems. And I'm sure it's a much vaster portfolio of analyses that you've done. One thing I'd encourage you to do, especially at that intersectionality between the organization of care delivery and health disparities, is to think about disparities and the measurement of disparities, not only at the what I would consider the provider level, but also at the structural level. So there's a hidden booby trap in the construct that you may have inadvertently portrayed, which is that health systems do great on care integration and they don't do harm on disparities within their population. But the reality is that health systems, which as we know in the marketplace are becoming increasingly powerful and large and dominant, they garner an increasing share of the resources in the system. And when commercial insurers have to pay prices on demand to health systems who have kind of must-have status in the market, it leaves them with that fewer resources to pay lesser health systems, particularly safety net systems that don't have the market leverage to negotiate those higher prices. And so you may be putting the lens on one aspect of disparities, and perhaps there's an opportunity to look at some other aspects as well. And by the way, those pricing differentials then creep back into public insurance programs, because when hospitals can say to CMS and to Congress that there's a growing differential between the prices that Medicare pays them versus the prices that they can command from commercial insurers, they portray that that is because of rising costs in care production, when in reality, it just reflects market leverage. And that puts pressure on CMS to raise Medicare prices for everyone. So just be aware of the booby traps in there.
So Maya, thank you. I'm going to answer that briefly because, those were results from a series of papers in an HSR supplement using data that was produced during the CHISP, initiative. What I want people to know is we have a compendium of health systems that has that data that's publicly available. And it includes data on safety net providers, rural providers, small providers. You can get a lot of the characteristics. You can look at their networks. So I would encourage you to let researchers know to use that database. It was most recently updated in 2018, and we're hoping to be able to update it with 2020 data so that we could capture the impact of the COVID pandemic on health systems. So those are all really important points, and we think we have the data to let people look at those important questions.
Awesome. Thanks, Arlene. Thanks, Mike, for the question. Susan, I think you're next.
Okay, thank you. And thank you again for these wonderful presentations. So I have two questions for Arlene. One is because I am involved in activities with IHI, and also our geriatrics group is one of the groups that's supporting the nursing home work. I hear a lot about that project, and what I mostly hear about are all the unbelievably challenging issues that people working in nursing homes are facing right now. Yesterday, I was on a call where they talked about one of the nursing homes that someone was coaching had 4 CEOs in the last 3 months. And so I'm wondering, and I'm not quite sure how to ask this question, but I'm wondering if through the work of that network and that whole initiative, which I think is amazing, is ARC able to garner and use issues like the challenges they face to help advocate for different types of policy reform or whatever to support, the care of elderly better or nursing home care better? I don't know whether that's something that's legally possible, but it certainly is a big issue. And I think you are getting quite a window into the challenges with this study. Or it's not a study, it's a quality improvement thing.
Yeah, I don't know, David, do you want to take that first, or would you like me to answer?
Sure, I'd be happy to. Thank you, Arlene. Susan, I had the privilege of helping launch the program, so I think that's why Arlene was passing this one to me. I think you hit on some really wonderful points. We are hearing and learning a lot. And I think if we're able to capture that and feed it back into what I think is going to be a multi-year national discussion on the future of the industry and how to care for America's vulnerable elderly, we'd love to do that. I think you did point out another part, though. This was an emergency authorization funded through the Provider Relief Fund. ARC always tries to learn from what we're doing, but we're rather constrained. This isn't a research or even a dissemination project. It was direct support in an emergency. So as we're coming to the end of the first level of the emergency, we're trying to figure out where the next steps and the greatest impact we can have. So we'll take all of what you just said into account.
I think it could be enormously helpful. My next question is also for Arlene. The work that you described that you're doing with NORC around creating toolkits around vaccine hesitancy. One of the concerns that many of the patient advocacy groups and other groups that are also doing work in this area is that they feel like it's been incredibly hard to get the voice of the public into some of these initiatives. The COVID-19 task force, you know, there were really no public members on, people representing patients on that task force. And I'm wondering if NORC is going to be doing qualitative work to get input from people in different communities about what the issues are, what the concerns are. I mean, I think we've got a pretty good handle on those, but I think that also sends a very, very important signal that their concerns are being heard and recognized and responded to. So just a question about the work with NORC.
Thanks, Susan. Can I take this
go
one?
ahead,
Arlene?
David, and then I'll add
Okay.
something
Well,
related.
so just so you know, that our work with the Nursing Home Initiative on vaccine confidence is actually very much targeted to nursing home staff and the CNAs. It's actually being done by the partners at IHI and the University of New Mexico through a subcontract with a group in Florida whose focus is on science communication to the public. And it is all based on focus group work, direct work with CNAs and people in communities about how to move this forward. We're really excited that it is going to be meaningful to the people, to the nursing homes. And we also recognize this is part of work that, and integrated with the work that our colleagues at CDC, at CMS are doing and throughout the department to reach out to the entire country. So this is only one small part of it. But in terms of your question, are we working directly with the people being affected? That project is completely based, starting from understanding what the fears and issues and styles and meaning to the people we are trying to reach are.
That's great.
I'm really excited about that one. Thank you.
Yeah, and
Arlene,
I think
yes.
the more you can publicize that, the better.
Okay. So noted.
Yeah.
Thank you.
And I'm actually gonna, kind of say something a little tangential, but I think it's really important to what you brought up, Susan, is that, so one of the other things that ARC has done is we've created a learning community of the people who support frontline primary care practices to address their issues under the pandemic. And they've been raising, like you're getting from nursing homes, lots of issues in terms of, switching to telehealth, maintaining prevention and chronic disease management during the pandemic, dealing with the vaccine issue. But, one of the things we've noticed at ARC is that in terms of relationships and vaccine and conversations, the people who are best posed to do it sometimes are the primary care communities, primary care practices in the communities they serve that are less likely to get it. And we do think that there's a huge opportunity that hasn't been tapped to engage primary care and really having conversations with people about vaccines and keeping themselves healthy during the pandemic. And unfortunately, that is still a potential that hasn't been tapped.
I think that's incredibly important. And I think that's something that we're hearing constantly from our patients because our state pulled all of the vaccines away from the practices and the health systems for a period of time. And it was chaos and people were incredibly upset. So I think that is really essential. And I just have one last question, and this is for, I can't see you on the slide. It's Mr. Cohen, Dr. Cohen?
Joel. Susan, it was for Joel.
Oh, yes. And the question is, the data that you showed, the curve about expenditures, that group, the 1% that account for 21% of the cost, how much of that is care in the last 6 months of life? Do you have any sense of that?
Yeah, actually, we can't do that with our data. It's a little hard to look at. I think the Medicare, people have used Medicare claims data to
Right.
look at a fair amount. I think, and I forget what the proportion is, but there were a couple of papers that were done the number of years ago on that.
Yeah.
And it's a fairly high proportion. So, you know, again, what we do know is that, you know, folks with chronic conditions and particularly multiple chronic conditions are the ones who are, you know, likely to be in that group because they're getting hospitalized, et cetera.
Right.
So if you're hospitalized, that's what really causes you to have, you know, very high medical expenditures. So, it's I'm not exactly sure what that number is, but it's a fairly high proportion of expenditures that are in the last year of life. The problem is, you know, Medicare can work backwards because they've got information on people. They know when they die, and then you can go back. You know, we're following people the other way. So, you know, we pick them up in the survey and follow them forward. So, you know, a few people die, but not that many. And then, you know, we sort of only follow people for 2 years. And so you don't really know when they die. So it's very hard to do the kind of study of, you know, last year of life. You know, with a survey where you're going forward rather than looking retrospectively.
Okay, thank you.
You're welcome.
Thanks, Joel. I think Peter, you're up next.
Hundreds and thousands of people, but very, very conservative. We are hoping to, you know, capture.
I think somebody's not on mute.
Yeah.
The market. I mean,
Looks like it's Ram. Yeah, thank you. All right, so just, I know we're short on time. I'm going to be rather quick here, but I wanted to jump back to the social determinants of health work. I think it's just so critically important, and I applaud ARC for the work you all are doing there. In particular, I think that beta data resource is really outstanding. Started to browse through the data descriptors myself. As you all know, there's incredible amounts of activity in this space for good reason, and a lot of parallel efforts, including in the standard space and others. The good news is I think there's great opportunity, you know, given all of the ongoing efforts to really help advance this conversation. What I worry about, and this gets to the opportunity and the question, is that, you know, very much like, you know, we've seen in the electronic health record and clinical care space, is that, you know, early on, it can be something of a Wild West. And I think there's an opportunity here to sort of head that off at the pass, where rather than what I think we're going to start to see with a lot of local investments from health systems and others, rather than the development of more proprietary and sort of non-standardized approaches, I think there's an incredible opportunity here for ARC to serve as a leader to add some coordination capability, some standardization capability. It's obviously a challenge because early on in these activities, you don't want to overly constrain. There needs to be innovation, but that has to be balanced with the importance of keeping an eye on not wanting to end up with a system that we're going to have to untangle down the road in terms of not being able to fully leverage these investments. So I would encourage that, and I wanted to ask what your thoughts are on having considered that, working with health systems, working with academic centers, as a lot of us are working on figuring out how we're going to leverage the social determinants of health to improve care and research. How do you see ARC playing a role in that coordination?
David, you might want to add something, but I'll go first. You know, basically, absolutely, we are concerned about that, and we are interested in one of the reasons we put up the, you know, on the slide, it said, you know, let us know what you're thinking. You know, we want to be able to, you know, talk to folks and coordinate. Certainly there's a huge group within the Department of Health and Human Services that gets together periodically to talk about what's going on. We're trying to coordinate across the department. Part of the project that that was PCOR funded was an environmental scan to talk to folks about what data they have, et cetera. So we are trying to make those contacts, you know, and be informed by, you know, other groups that are looking at this. But you're absolutely right. It is a little bit of a Wild West, and everybody's kind of doing their own thing. You know, there are groups out there that are, you know, looking at ways of standardizing and reporting, et cetera. So, you know, we are trying to do what we can. I think, you know, the thing that we were kind of surprised at when we started this was, you know, everybody's talking about social determinants of health, And, it's like, well, what database do you have that you can link to? And it's like, well, I don't know of anything. So we were really happy to get this one out. I think just doing that is going to create more conversation. And I think, yeah, exactly what you're talking about. We want to coordinate. We want it to not be a Wild West. You want to have data out there that are consistent, that are standardized, that are well documented. A lot of it, in our environmental scan, a lot of what we found was, there's data out there that people talk about. It's not very good. And you want to know that. So, we are sensitive to that issue. We are trying to do what we can. We are trying to coordinate, both within the department and the federal government and outside as well. So that's part of
great.
the project.
I think this is a really, really important area. So thank you for your leadership, and I applaud you. I think that's this could end up being just another one of those marquee programs that really, really drives the improvements in health. So great work.
Yeah, I agree with Peter. I mean, I think that, jumping in and from a leadership perspective in this specific topic, I think is right in line with our commission and really the skills and tools that you have available. So I really would want to, I second that. I've got, I appreciate David ceding a little bit of time later in the agenda so we can continue this conversation. I've got a couple other questions on the list. I've got Gretchen coming next, and I got Ram. I see you after Gretchen.
Yeah, thanks. At risk of going a little bit back to the nursing home question, and I know we've talked about it a lot, but I was wondering, David, if there's anything more you can tell us about evaluating the effectiveness of the nursing home network, both short-term and long-term, and what kind of time frame and content that entails, and also whether evaluating the effectiveness of the network is somewhat obscured by the obvious favorable impact of immunization on nursing home residents and staff.
Great ARC question, Gretchen. One of the great tensions with this project, as when we were talking with Susan, I mentioned, was the need to get this out there and do it, and ARC wanting to evaluate and learn from it at the same time, and recognizing that we were not authorized to do research with it. And we have a phenomenal team of thinkers here at ARC from across the agency that came together, that brought the skills to make it happen contractually, that brought the skills about quality improvement in a safe environment, and then the evaluating team too. So we do have both an internal evaluation that UNM is working on. So the training centers themselves are trying to understand what worked and what didn't and how people benefited. That is limited, however, because we don't have the ability to get to the people who chose not to participate.
Oh.
So that's what would be needed to get the perfect evaluation of this. That said, the other problem we have, even before that, we also have an external evaluation, and our colleagues at NORC are putting together some other data sets and partnering with CMS and trying to be able to compare those who participated and those who don't. So we do hope to be able to say something about how the network affected these nursing homes in both a qualitative way and a quantitative way. So we are looking to be able to do that as best we can. Our goal, though, really was helping them survive, to protect their residents and their staff. And just very quickly for the NAC to be thinking about, this is a really wonderful opportunity to put all of our patient safety work into real practice in a new setting. This was helping systems who understood their goal was to keep residents safe, but didn't necessarily have all the skills. So we were doing a lot of foundational work. Now, some of the nursing homes were much more advanced, and that was one of the nice things about this model is it met people where they were. So for those who were starting out, we taught them what a huddle was and why starting each day with your team together and coming up with a plan helps create better care. Others had already been doing that, and the level of questions they were asking was much more sophisticated, and the training centers could meet both of those groups. The first lesson we learned, though, in this network, which won't show up in, I think, the mortality rates, but we may see in other ways, is that the nursing home staff were feeling extremely isolated. In fact, at times this summer, they were feeling demonized, that they were actively killing the people they were caring for. And just giving them the space to meet other nursing home staff around in their communities and find they weren't alone, immediately engaged them and kept them engaged. So just the level, at a level of keeping these healthcare workers from burning out and to feel valued, I think is going to be one of the values that we're going to be able to show of this network. So thank you for asking.
Yeah, that's great, Dave. Thanks for sharing. I think we'll take the last question here with Ram.
Oh, thank you very, very much. And thank you for all the great work you're doing. It's really impressive what you guys have done. And I just have two quick issues which we can do that. Your attempt to create a database for the social determinants of health is absolutely laudable, and that you are on the right path, and thank you for the leadership. But there is an easier way to get the data. One of the things, our consternation is we don't have enough data on social determinants of health coming into the electronic medical record or into the data system. It can be easily be solved because we do have a tool under the ICD-10 Z codes, which basically captures the social issues of the people, are not being kind of used extensively because there is no reimbursement based on that. Even though we have shown in some limited studies with the same CMI, because we can reimburse according to the clinical severity, not the social risk as a part of it. You could have the same CMI, two different zip codes. One zip code costs you more money than the other zip code because of the Z codes not being done correctly. So we can really tie this as a policy of the AHR, take a lead, tie this to a reimbursement system. Just like we pay for clinical severity, we can also pay for social risk factors, severity. Then the data on the social determinants will flow right into the data because every hospital has got the coding team, which is sitting down and trying to figure out how to get the CMI correct. And the same effort will be put into creating what we call a social risk index. So that's one issue. The second issue is I agree with David that the people who work in the nursing home, the medical staff and the ancillary staff are working very hard and they deserve so much credit. But the management of the nursing home, since about 70% of nursing homes in the country are privately owned. And we also know that the STAR system of nursing home is not really it doesn't really reflect the care given the nursing home. So as it happens that we have exposed one social inequity due to COVID because of health equities, vulnerable population, it also exposed the shortcomings of nursing home system in this country. So I think whatever we could do from AHRQ, whether you fund something and look into that, I think this STAR system need to be relooked at and say how we can improve that in an effective way so that we are able to really gauge the nursing home's performance in a meaningful way. Because people do depend on the STAR system, choose a nursing home for their parents and other loved ones. So I think we have a social obligation here to do that. Thank you.
Great points, Ram. Thank you so much. And I'm so glad our colleagues at CMS are here. They are committed to doing much of what you're saying, and ARC will be a partner with them in doing that. I think ARC will continue also, though, to play a role in whether or not there are ratings or payment changes or policy changes, legal changes at Congress, providing support and trying to create a safety and quality culture and skill set within the care system and bring nursing homes closer to where the rest of the healthcare system is. And by the way, my team's already asking me, what about home health? What about independent living centers? So yes, we are aware of that too. That's where we'd like to go.
Thank you.
David, my mistake I made, Yanling actually wants you to go ahead and go now. I dropped you off my list. So Yanling, go ahead. You had a question and comment.
Oh, thank you very much, Antonio. My question is to Jeff, Eileen, and ARC is doing great work to found the researchers to develop practice guidelines based on evidence. And I was just wondering if ARC have done any work or has planned to have some measurements on how facilities and healthcare providers to adopt those evidence-based guidelines and what barriers they are.
I think, did you say
Yeah,
that was for
yeah.
Arlene? You want to
no,
go first?
I'm happy. Yeah, I'm happy to answer that. So I think that's a great question. And I think that's one of the primary, missions of our practice improvement work is to get evidence-based guidelines into practice. And we're doing it in a couple of different ways. Some of the dissemination and implementation projects that I presented are actually about getting increased uptake of evidence-based guidelines. So we actively promote, and we actually have a public nomination process to nominate topics for our dissemination and implementation initiative. We look for areas where there's a huge public health impact, a gap in practice and strong evidence, and the ability to kind of move the needle. So if any of you have ideas for where we should be investing around practice improvement, please, there is a public nomination site and we welcome your nominations. I could put the link up in the chat in a little bit. The other thing we're doing is with our clinical decision support, and we have a vision of a real, an information ecosystem where we could quickly go from doing, the research to synthesis to the clinical practice guideline and then to clinical decision support to make it easier to get evidence at the point of care. And so the work we're doing in clinical decision support, the work we're doing actually in our EPC program, we have a number of things that we're going to be rolling out soon to be able to do better data visualization and access our reports, are all part of our goal. And we welcome ideas from you, like how we could be doing this better, because we know it's challenging and we know that's key to really improving care in the country.
I'd briefly add just two key points on that. One is that what we see in our patient safety work is the better integrated measurement is to the work itself, engaging frontline providers where possible. That's almost a necessity for many improvement approaches. And so to the extent that when you're talking about guidelines, you're talking about improvement projects as well, changes in care to sort of improve safety. Again, that integration is key. And the second brief point I would make is, I think as everybody's aware, increasingly trying to get the most out of digital healthcare. And I think the burden of measurement hasn't gone away. I'd like to see those discussions shift from the burden of measurement to the efficiency of measurement, and ultimately to a place where providers are, sort of seeking this information to help guide their care. I think that's sort of still a visionary kind of a target where we stand now. But when we have frontline providers actually looking for this information, making real-time decisions where possible, I think that's one of the keys to better integration of measurement. Great question. Thank you.
Yeah, and actually, I just want to add to what Jeff said, because we know one of the places where guidelines fall short, Jeff was mentioning about like the high needs, high cost patients or people who have multiple chronic conditions. And we haven't done our research or developed the evidence for how to best manage, multiple chronic conditions. And we have to make sure that, implementing evidence on one disease doesn't harm the other or lead to actually suboptimal care. So we're really interested in how do we advance what is the best practice and what is the evidence for providing care for people with multiple conditions when there's trade-offs. So I think as we work on measurement and implementation, we also have to look at, potential harms and unintended consequences, and we're doing that.
Thank you. If I may, I just one quick comment. And it's great, like Jeff mentioned, also the virtual digital, care, and that telehealth that really increased during the COVID pandemic. And I just want to have a cautious note, that is that the telehealth had in some area is appropriate, in some area it may not appropriate, it may not place the traditional that, the doctor have to listen to patient's heart and had to lung and do the lab work. And also there's a research, I think, by ARC supported research that shows that there had been an increase in antibiotic prescription. So I hope that's we would address that, that make, even though it's very convenient and very helpful to both providers and patients in this type of a care mode, but I have to be very cautious that we definitely meet a standard care, in terms of, prescribing and diagnosis, avoid diagnostic error.
Yeah, sure. No, very briefly, you covered a lot of ground there. So I was specifically referring to the digitization of healthcare generally supporting measurement. I think you make another great point, though, that the role of telehealth, I mean, that has sort of pervaded the agency, I think, in a good way. So the entire agency is, I think, activated to consider how telehealth is changing care and how we might actually improve care with telehealth. And that dynamic sea change is definitely, I think we're responding to that in many different ways. And then diagnostic error, of course, I think both that and the problem of antibiotic stewardship in general, both of those problems, and also with respect to telehealth. So yeah, there's a lot of dimensions to these changes, and I think we're trying to tackle them, in due course. But lots of research questions have been put on the table based on the last year, and I think we're starting to check them off. So thank you for all those points.
Can I just encourage us here to pull back a little bit and scope out, because I think there's another large opportunity here for multiple lanes in ARC's work. When we talk about the digitization of care, I think it's important to look for an opportunity to approach that phenomenon, not with our current paradigms of what care delivery means. There are now, every day I get feeds about new companies and new entities, merging, acquisitions, hybrid models of care delivery that include some digital components and some not. I am very concerned that our entire national research infrastructure has not adapted to this new reality yet. I am very concerned that Medicare is not really able, through the NPPS, to see all of the individual entities that are now delivering care, and to define them in ways that actually reflect the reality out there, as opposed to our old paradigm of bricks and mortar, and a given provider entity is in one state, and a given provider entity is either recognized, vertically integrated health system or medical practice, or that is no longer true. And it will increasingly become out of date, that paradigm. And I worry about that lack of fluidity and nimbleness in the way that we are structuring even the data that we are looking at. So just raising that for you to noodle on. For example, I don't know what's in the health system compendium. Would it reflect, an outfit like Heal Health, which has never had bricks and mortar and is in 16 states, but serves, a multitude of patients and has partnerships with other providers. So how can you tell which patients belong to them? So it's those kinds of things that I think it may be worth ARC maybe even able to lead the rest of HHS in thinking about. I'm pretty certain that your sister agencies are not ahead of you here.
I think it's a great point, and I'll shout out to one of our LEANS programs, actually the Digital Healthcare Research Program, and how it's not only focused on its own kind of targeted work, but it's helping to inform, I think, other parts of the agency. And I think a lot of the things that you described, Maya, are sort of reflected in their conceptual framework, and I think we're trying to do exactly what you described, which is get a handle on not where things are, but where they're headed, or where they could be headed. There are lots of opportunities, I think, present in the changes that we're seeing. But I think our role, and I'll defer to David and Arlene and others, but I think our role is to sort of help chart that and ensure that it actually does support improving, healthcare outcomes and quality, safety, et cetera. So equity. So I'll stop there.
So I want to thank Mai and the rest of the NAC members, because we value when you push us to think beyond what we are already thinking. So we gave you where we are, and that's the exact kind of comment and Ram did some of those, and Susan and Yenling, that make us uncomfortable, ask us to do things that we're not ready for yet, because that's the only way we'll get ready. So thank you for doing that. Armando, do you mind if I move on just to see?
Please do that, David. Thank
Okay.
you. We're going to move on to the ARC update.
So this is me, or that's what I used to look like. And I get to serve right now as the acting director. And the job of an acting director is actually quite an odd one. It's sort of fun, but I'm not yet the captain of the ship. I am keeping the ship safe until the captain can come on board. And I am not allowed to turn our sailing ship into a spaceship while I'm in charge. The good news, though, is that I have a phenomenal crew and a phenomenal team here at ARC. You just heard from some of the leaders. There are many, many more on the phone today listening to you all, who know their jobs, who are passionate and committed to their work. So we're moving forward. I'll show you in a minute our budget and what we're doing to achieve that. But I also wanted to make sure that you all knew that the new administration has brought with us some new North Stars that we're charting our course by. COVID is moving from response, which we still need to have our eye on as a department, but ARC is thinking about COVID recovery and what happens next, and how to support long haulers, and how the healthcare system has been disrupted, and how to keep it and building it forward. Second priority, health equity. We've talked a bunch about that already. ARC has a long history in this work, but there is a new momentum, and the entire agency is vibrating with excitement about how we can make real change and have impact for the American people. Healthcare access is back on the map, and that's exciting. Our new secretary designee, Xavier Becerra, his hearing at the Senate, his full vote for confirmation should have happened. I don't know if anybody's been watching their feeds. It was scheduled to start at 10 a.m. today. So we are expecting Senate confirmation for him, and he'll be taking the helm. And that is an area of great passion for him. And finally, ARC is thinking about a fourth challenge to HHS to understand how climate change is affecting health and healthcare delivery, and the effect of healthcare on climate change, as well as a third area of climate justice and how it intersects with health justice. And at ARC, we're starting the process. This is a new area for us of how we could participate in that discussion as well. Next slide, please. Wanted to make sure the NAC understood where we are. We're about halfway through fiscal year FY21. Congress did pass a budget. It gave ARC the same amount, $338 million in appropriated dollars from FY 2020. So we were in a good place, and certainly a little bit of a sigh of relief that we didn't take the $72 million cut that was proposed in the last president's budget. There's a slight change in the budget for how ARC can spend the money. In addition to our colleagues at MEPS to expand their sample size, which is very, very exciting for us. Unfortunately, they didn't give us extra money to do that, which we were hoping for. And so we had to do a little bit of what's called a haircut across some of our other programs to make sure that was possible. But the teams, I think, are doing really, really well with that. We are very excited that I think we've got through this last cycle. ARC was maintained by Congress with pretty strong language as an independent agency. I am hopeful that with a new administration in the White House, a new OMB, new leadership at HHS, and a new Congress, this may be a thing of the past, and that ARC's recognition for ARC's value may continue. Next slide. I also actually, yeah, here it is. The note there is at the bottom. When you think about that budget of $338 million, it's also important to remind the NAC that ARC receives funds from the PCOR Trust Fund, which was established under the Affordable Care Act and reauthorized in 2020. We're going to have a whole presentation in a moment about what we're doing with those funds, but that gives us some extra flexibility this year and in the future, and to respond to some of these new priorities, some of the priorities you heard the team already talking about, and ideas that we're getting from the NAC. People are asking questions about what happens next year. With the new administration, they often first prepare what is called a skinny budget. And that means a budget that's at the department level, that doesn't show you all the breakdowns of in HHS, how much goes to CDC or FDA or CMS or to ARC. That process is in place. We expect that'll go public sometime in the spring. And then most likely the administration later in the spring will be moving on more detailed information. And ARC looks forward to helping support them with that information and what their vision for us is moving forward. Next slide. I want to, whoops, no, actually stay there for a moment. Thank you. Edmondo, you are walking into a new thing, both as chair, but also in your last NAC meeting. The NAC approved what we call a SNAC, a subcommittee of the National Advisory Committee, to focus on the future of quality measurement at ARC and what ARC's role in the developing quality measurement ecosystem should be moving forward. That was part of something called the quality roadmap. Whether or not the roadmap will be taken out of the drawer in the future is actually not so important to me as is the question of where stakeholders want ARC to go, where they see the greatest impact or not in ARC in the quality measurement enterprise. That work has now been, Jamie and her team have the contracts. We will be starting that very soon. We do have a request for you though, right, Jamie, that we need to vote? Do we need to vote on this?
You want to do this now?
Yeah, I was going to.
Yes.
Yeah. So what we need for NAC members is an extension on this subcommittee of the NAC through the November meeting. So and that does need to be moved and voted on. So do I hear a motion to extend this?
Motion to move forward.
Motion heard. Second.
I see Peter.
Yep, there's a second from Susan. So the motion's been moved and seconded to extend the SNAC on quality measurement enterprise through the November meeting. All those in favor, aye?
Aye.
Aye. Aye.
Opposed? All right, that motion carries. You can keep going, Dan.
First official business. Thank you so much, sir. I'm really glad you all did that. What that's going to mean is we're going to have more time with you to do more work in this new paradigm, so or in our new context. So I think that was a very wise choice. Next slide. There we go. So I gave you a little bit about where I'm feeling. I gave you some of the North Star. I told you that the secretary is a designee, hopefully will be the secretary. My expectation is he'll be sworn in the morning and take over. That begins the process, or will continue the process of ARC finding its way. We're in a good state, however. As we said, we had the budget. We're working on these priorities that you've heard about internally, things like diagnostic safety, care of people with multiple chronic conditions, primary care, expanding our data resources with a focus on making them available to policymakers, as well as dealing with equity. We're going to engage the NAC this afternoon in a discussion of where we're already thinking about equity to get your advice on where some other opportunities to expand our thinking on that. And we expect by the next time we meet you, which as Jamie said at the beginning, will probably be a virtual meeting, that we will get to introduce to you a new director. Happy to answer any questions about where we are, where we're going, the transition, the budget. We have a few moments, and then I'm really excited to introduce a new member of the ARC team to talk to you about our work in the Peace Corps Trust Fund before we break for lunch.
Right, so any questions on David's updates?
I have a question.
Go ahead, Patrick.
Yes, I'm wondering if you could just address, obviously, it's been in the news a lot, the $1.9 trillion COVID-19 relief legislation, American Rescue Plan Act. I know that there were a number of provisions in that bill to expand coverage and to provide more support to states related to coverage improvements. Are there any particular implications for ARC in that act?
Great question, and I wish I had a different answer, but no, actually, Congress did not specify ARC any of the activities under the American Recovery Plan. So we'll stand by to help our partners in the department implement some of the bigger things where appropriate, and the Office of the Secretary as necessary, especially with data and measurement and evaluation components. There were no research components to the American Recovery Plan, which would have involved ARC. We are interested, there are still funds available in the Provider Relief Fund, and thinking about how to continue to help support health systems moving forward. That is money that was provided earlier, so to use our practice improvement and patient safety experience moving forward. There are calls for more data and integration of data, mostly through executive orders, not funded through the ARP, which we are also very, very much engaged with. Good question. Thank you.
And I wonder if there may be opportunities for partnering with some of your sister agencies to look at the impact of some of those efforts, you know, for example, with the whole issue of disaster preparedness in healthcare with the additional money that's gone out through FEMA, as well as, of course, the impact of access improvements through additional money that's being put out through to support the exchanges.
Great point. And we're with you on that. We will look for those opportunities.
Great. David, do you want to introduce Dr. Rhodes?
No, I think you've got it, but I am so proud and so excited that you're going to do that. So thank you.
Double checking. All right. So though very, very pleased to introduce Dr. Karen Rhodes, who's new to ARC, but well accomplished and really we're really excited about this discussion around the PCOR Trust Fund. So Dr. Rhodes is the Chief Implementation Officer, and also the Director for ARC, and we're just really looking forward to this conversation and Karen joining the team here and us and being able to interact with her as part of the NAC. So Karen, go ahead and take it away.
Okay.
Can we advance the slides?
We have slides.
Next.
Next slide, Jen.
Next.
Next slide, Jen. Thank you.
So as David mentioned, I've just joined and haven't had a chance to do so much. So I'm going to focus my talk on telling you what I've done in the past. And then a couple things I want to cover, what the PCOR Trust Fund is and my thoughts on moving forward on a strategic plan. And I want to save time. I know we're running a little late, so I'm going to not really cover too much of the things that have already been really well covered by my colleagues in much greater depth. So I'm going to tell you about my background. I took a very circuitous career path that included community organizing and working as a nurse until my third year of medical school. I did an internship in primary care internal medicine, and I worked as an ER doc while I had small kids, volunteering with my local health department on community health needs assessment, ran an HIV education task force, and started a hospital-based domestic violence intervention program on Chicago's West Side. When my kids were both in school, I returned to complete an emergency medicine residency and was lucky enough to get into the RWJ Clinical Scholars Program at the University of Chicago. So my academic career was launched when I got my first R01 from AHRQ, actually when I was still a fellow. So later I moved to the University of Pennsylvania, where I think you've been, Armando, and I started a center for emergency care and policy research and led numerous research teams testing emergency department and public health interventions for health-related social risks. Domestic violence, substance abuse being the most prominent, but also very involved with mental health issues. I also led a multidisciplinary set of research teams that worked across both Penn and CHOP, the Children's Hospital, to innovate around improving transitions in care. In 2000, while I was at Penn, actually, one of my most notable accomplishments was my use of simulated patient methodology to measure access to both specialty care for children and later primary care. I was funded by RWJ to lead a national, highly talented team of economists from Leonard Davis Institute of Health Economics and the Urban Institute. tracking the impact of ACA insurance expansions on access to care, to primary care in 10 diverse states. We found access increased significantly, but only in states that expanded Medicaid. And we had multiple other side projects related to that, very exciting findings. And we were able to take them directly to policymakers. And that excitement about seeing the impact of our work on both state and federal policy really drives a lot of the excitement I feel in this field around having impact. So in 2015, I moved to Northwell Health, where I got to know Ram Raju. I was a vice president for care management in their business unit, moving that big health system, trying to move the big health system towards value-based care. We very much focused on that top 5% that was 50% of the spend, and addressing the complex care needs and social determinants of patients across the continuum. Some of the more exciting projects I was involved with involved increasing access to mental health services for school children. And on the other end of the age spectrum, we had a home-based primary care program, and we tested the use of community paramedics and use of telehealth to support home-based primary care. During COVID, we were able to rapidly pivot and expand the work that we had started there in a very successful way. In 2017-18, Northwell sort of sponsored me, and for a year in DC, I was a RWJ Health Policy Fellow, and I got to work in both the Senate on the Health Committee and later in the House of Representatives with Michelle Lujan Grisham, who is now governor of New Mexico. Subsequent to that, I had a period of time where I served as director of public health for the state of New Mexico. I was back in New York during the most recent COVID-19 pandemic surge, and I worked with IDEO, again funded by RWJ, a big benefactor, to do some human-centered design. And we organized emergency medicine leadership and frontline providers from across the New York City area to help with a goal of breaking down silos across these competing health systems, sharing regional knowledge, and improving health equity and health security, public health preparedness in the future. So that's my background as Chief Implementation Officer, and I am extremely honored to be here at ARC with these incredible teams. I am charged with, among other things, strategic planning for the ARC's PCORI Trust Fund investment. So in this role, I can both build on, and I'm still learning about, the first 10 years that ARC worked with ARC's experience with the PCORI Trust Fund. And now that this fund has been reauthorized, the past year, they have done a fair amount of strategic planning already regarding how best to use the funds. And at the end of this, we really want your input into this too. And because I am here and just learning, I was going to do a very basic update on a few things that I've learned about. So I wanted to start with first some definitions. Next slide. So patient-centered outcomes research is essentially just comparative effectiveness research. And a lot of people from ARC went to PCORI, the Patient-Centered Outcomes Research Institute, which is a quasi-governmental nonprofit independent organization that was established with the goal of helping patients and clinicians make better informed decision makings by advancing clinical effectiveness research, CER. And cool thing is it was recently reauthorized, and now PCORI is being encouraged to consider a broader range of patient outcomes, including accounting for cost as a patient-centered outcome. So what we've got here in the trust fund, which is ARC's piece of this, is about $100 million a year. The trust fund is basically comes from annual fees on health insurers and plans that supports this process. And next slide. There are portions of the trust fund that are authorized to the Institute, PCORI Institute, most of the funds. HHS, which is to develop the PCOR infrastructure, which is sort of the data systems like the social determinants of health data that was you heard about earlier. And ARC's role in this as this was signed into law under the ACA was to disseminate the evidence and with a long-term goal of improving healthcare with evidence. And so go to the next piece. There were two areas that ARC was required to, that really built on ARC's core mission and experience. So training, and that's training to build the skills for researchers so that they can do future comparative effectiveness research, and dissemination, which is to disseminate and implement the findings from not just PCORI, but also other government-funded health service entities that sponsor research and do comparative effectiveness research. And in the process, we're also supposed to support the incorporation of these research findings into health information technologies. And we're doing that through a lot of work on digital health, specifically the clinical decision support system. So next slide. So ARC has had a full range of funding announcements across the years, and supported the training and career development of researchers in doing patient-centered outcomes research. And in addition, they are beginning to deploy new models and mechanisms such as educational products, center grants, cooperative agreements, to really build the research capacity in both academic settings, but also through embedding researchers in health systems who can focus on operations, quality, and system improvement. So a lot of this is informed by the learning health system model. And they have added a focus on mid-career researchers and scientists, because there's a little bit of a gap between the career development and then jumping to your first R01 and being able to become an independent researcher. And they've added a focus to reflect, to work on disparities, and also to do dissemination and implementation science. So currently there's an evaluation going on PCORI's training initiatives, and we can fill you in on that in July. Next slide. So you've around our D&I work, the competencies really focus on evidence synthesis, which is the heart of everything ARC's doing, and then translating and communicating that evidence to policymakers and frontline providers, and then working on implementation into clinical practice. And this is not a linear process, really. So we put that cyclic, it's more of a rapid cycle improvement that can support health systems and professionals to implement the evidence into practice and through the development of tools as well as the training and the outreach. Next slide. So you've already heard a fair amount about AHRQ's clinical decision support. This is sort of their analytic framework that really deals with the interaction between clinical decision support and current laws and policies around health IT. And it also is not a linear process because there are rapid changes in the digital health marketplace and trying to figure out how to make things publicly available, accessible, interoperable, and deal with a competitive marketplace. And the private side of this is a really exciting sort of challenge right now. So more on that and more to come. They have some really great ideas in the works right now. So next slide. So I am not going to go into this wonderful Evidence Now initiative, but suffice it to say that our early positive learnings from the working on a regional level to advance heart health has morphed into doing a state-based implementation, which is great because states have the same Medicaid policies and health systems. So I think this is going to be a very interesting part of it. Is you've already heard from Arlene about all the great grant initiatives, but this enhancing state capacities, and they're focusing on areas with high rates of cardiovascular health. But in the process, we're hitting a fair amount of states, and there's some overlap. And one thing that's really important is that there's ongoing rigorous evaluation of this. And so there'll be more to learn on that and present on that in July as well. So there's already been some talk about the Comparative Health System Performance Initiative and the compendium. And I noticed in the chat that Patrick and a number of people have said, oh, this needs to be updated. And we agree. It's from 2018, but there's been rapid change in the US health systems over the past 3 years, and with and the health shocks and economic shocks hitting the health system, I think it's a really key role and a good use of trust funds to understand the context in which care is being delivered as we try to get evidence and safety and quality into the healthcare system and see how well they're doing. It'll be important to update that. And I find that a really exciting piece of it. And that system, though, has been used, it's been a resource used by a lot of federal partners, researchers, and policymakers. And recently, they're linking it to the COVID research database. And we do have 2020 data that we're hoping to get there into it shortly. So finally, next, I'm sorry, I forgot to say next slide. There's our beautiful graphic of the health system, various US health systems by payer status or by the way they're funded that we hope to update. And I'm sorry, I was a slide behind there. Okay, so finally, next slide. I want to get to my list of goals and what I see as next steps for strategic planning and investment for the PCOR Trust Fund. So again, I'm building on what's being done to date. I'm looking to develop an overarching framework that will incorporate AHRQ's goals, and at the same time while we do this, I'm hoping, and I'm meeting, actually, I haven't even had my first full meeting yet with the leadership at ARC. I'm hoping to get them to establish some priorities. ARC does lots of things, super breadth and depth in areas. But I think for the trust fund dollars, it would be nice to have some broad priorities that sort of intersect also sort of a matrix with the administration priorities, and then use that to help develop the spin plan. And as part of it, I want to establish some transparent governance for it, some real clear decision-making on how to spend this money, and accountability for the funds. And a long-term evaluation plan with some very clear metrics of success. So this is going to take a while, and I will look forward to your input. We're going to take a certain percentage of it to invest in some needed ARC infrastructure related to staffing as well. And part of my role is to sort of work across ASPE, PCORI, and NIH. So working on implementation and dissemination and policy implementation with those organizations as well. And the key thing here, next slide, is to ensure appropriate stakeholder engagement. And for that, we have several questions for all of you and would love to open it up to discussion. So could you go to the questions for the NAC? Next slide, there. So Edmundo, do you want to run this part or?
Yeah, we can do that. We have a couple of minutes to do so. I don't want to take everyone's. I want to make sure people actually also have time to take some time to eat. But let's go through a couple of these questions and see if we've got some feedback and input from the NAC. I think it'd be great. And thanks, Karen, for your presentation. It's always an honor for me to introduce a fellow RWJ clinical scholar in any setting. So the first one here is what are the biggest issues health systems are dealing with today in the next 10 years that really could better use evidence? And so that's just one to kind of ponder for the NAC. And what I'll do is I'll just read through 3 and then everyone just kind of chime in on any one that you think is useful and follow up on. The second one here is how best to track and inform new models of care. And we talked a little bit about that around digital. I think Amaya has some really interesting perspectives on some of these new models of care, telehealth, home-based primary care, hospital home, and so forth. What's the best way to actually go about tracking that, informing that, and really kind of bringing that kind of information and spreading it within the organizations and areas that need to know about it. And then the last question is how does ARC remain relevant during this time of rapid consolidation and changing models of care? So really the kind of the questions really flow here, right? So one of the biggest issues to deal with is these new models of care, right? And then what's ARC's role in working through that? So I'm going to go back and look at, because I saw questions or comments coming in through chat. I think I saw Yangling first. So Yangling, you had go, and I'll take the order after that.
Thank you, Armando. My question, I really like the first question about how to, in the next 10 years, how to incorporate better use evidence. I think one of the great evidence and resources we probably hasn't been well used is evidence from patient, real world experience from patient. And I was just thinking, there's, in particularly, I'm thinking about open notes, and that would open a door for patients and family members to input their feedback on the care and quality or the safety concern, whatever they have, so that it would be documented in the medical records and then be collected with analysis and tracking. It was a great resources for patients' perspective to be included, in the healthcare. And I know the Open Notes has now been widely adopted, And I just wondering if ARC would have any plans in the future to work with any agency, private, industry to work on that, to open the door for the, the consumers and patient families.
All right. I mean, I think those are great comments. And I think, again, I Open Notes, I think is a great, it's a great kind of general, kind of construct to build around digital. Whether or not, a lot of the questions on that, I think, are actually implementation of the concept. I think part of that's part of the struggle. And what's the user interface? What's the user experience around actually accessing your notes? Those kinds of things. I think there's a lot of work to do there, and there's probably a research question or two around. Frankly. So I had Greg next. He's working on.
Sorry, I was trying to find the mute button. Yes, thank you. These are great questions, and I think so. I come at these questions from a perspective of long-term care and nursing homes and assisted living and continuing care communities. And so there continues to be, in regards to question number one, there continues to be a great sort of disparity between the use of technologies that allow for interoperability between long-term care and acute care settings. And I continue to think that will be a big issue, remaining issue for the next 10 years. And it's still a current issue because there's just many gaps in the ability to exchange data and information to keep care current. I also think that the new rules and regulations out of ONC that relate to information blocking could have some big impacts on long-term care, if they're not really prepared to be able to share information electronically, either because the infrastructure is lacking or they don't have a workforce that understands it, or they don't have the funds or models to be able to implement that. And then, with the COVID pandemic and everything that's happened over the last year, their care delivery models have changed drastically. They've all of a sudden had to pick up and use telehealth, and oftentimes that means just picking up a phone and calling somebody, and they call that telehealth, and it may be, but they are using a wide variety of applications across homes. There's really not good evidence in these communities about how telehealth is being used and incorporated. And now that we've opened that box, that sort of Pandora's box, and it's being integrated into the care delivery systems that they're using now, I think it will be hard for them to go back to previous ways of doing consultation and providing second opinions and getting families to interact, utilizing telehealth. There's so many ways they're using it. And I think that those models of care will evolve over the next few years, probably sooner rather than later. I just think it'll look a lot different in the next 10 years. And finally, I think that will introduce some different kinds of quality measures. The quality measures are sort of under fire a little bit recently. If you've seen the most recent New York Times issue, the article that was published a couple of days ago about the 5-star rating system and quality in nursing homes, and the gaps in data that is apparently there. Those issues may spark some big change in the way quality measures are used. And I think ARC, because it focuses on quality by the mere title of the organization, that it would be imperative for us to be part of that solution of getting better quality measures in this space that make a difference for older adults. Thank you.
Really appreciate those comments, Greg, and really one timely and impactful and things that I think we're dealing with on a daily basis, quite frankly, right now, and really need to figure out how what the future is going to look like. I don't know, Dave, if you want to add anything on that. Okay, great. No, really good. And so again, Karen, I hope you're capturing some of this. I think you have some rich comments here. I think Mai was next on my list.
Thanks, Armando. And Karen, congratulations. A great perch after a storied career. Several thoughts and suggestions for you on questions 2 and 3 in particular. And I think taking a step back again, I think here's an opportunity to think about what ARC's future research partnerships could look like, because I think that will determine how well you are able to accomplish 2 and 3. And some suggestions there to help concretize that. So, how do you track new models of care? There is no existing database that you can reach to, right? You're trying to create that database. Well, who knows? It's usually people that ARC, I don't think, typically interacts with. I think it is the venture capital community. I think it is the healthcare benefit managers and consultants. I think it is generally healthcare consulting firms like Milliman or McKinsey, right, whose job it is to track these industry changes and to really have a hand feel for not just the trends, but the individual organizations. Now, I don't think any of them have databases either, but I think that if AHRQ could come up with a process, an efficient process for you to be continually getting updates and feeds their intelligence, that would help you feel much more confident that you have a handle on at least the shape of things. And then you can start thinking through, okay, well, what are the best ways to capture in data these various entities? Is it still NPPS, but we're looking for a different kind of data construct when we look in there? Is it looking, is it going to the IRS and asking for EINs? Is it looking for where corporations are incorporated? I don't know. But I think the first step has to be just getting a better hand feel for the industry itself and who your intelligence sources might be. I think related to that, when I think about how best to track those things and how to remain relevant, I wonder the extent to which ARC has invested in predictive analytics and specifically to have staff who are expert in predictive analytics, which often doesn't overlap with expertise in epidemiology or healthcare services research. They should at some point, and I think there are a growing number of people who hold both skill sets, but I think it may be really critical for ARC to invest in that. And the reason why is because I think you will see different kinds of opportunities when you have colleagues like that. So for example, I think about what ARC might have been able to do in the early days of COVID that individual payers had to figure out how to do willy-nilly on their own. Anthem, for example, realized, well, they weren't public health experts and they weren't on the ground doing the clinical work. How could they add value for their clients who are employers? So what they did was they scraped data. They took their claims data, but they also scraped public health agency data. They took data from international sources. They found any publicly accessible data they could, and they layered predictive analytics on that to predict the probability that a given person would be at increased risk for COVID mortality should they become infected. And then they were able to feed that back to providers in their ACOs so that those ACOs could at least have the conversation and know, okay, you should not come into the office unless you absolutely need to. And here are the triggers for me telling you to come to the office because you're at increased risk, right? This was at a time before there was sufficient data in the published literature for anybody to go on. I think ARC has more than the capability to be useful in that way in real time, or even if not in real time, to think about, wow, I mean, the potential is limitless, what you could do with the data you already have if you layered predictive analytics on that, and then made those constructed variables available to others, and or just spit out different probability estimates for various phenomena that researchers and policymakers may really need to know. We can brainstorm offline about what those opportunities are, but I just wanted to pull you back and offer that, there's, instead of trying to keep up with the Joneses, you can just marry the Joneses. And from that perspective, I think it's not just having staff, it's also thinking differently about, gee, who could our data partners be? Maybe it's time that ARC partnered with Google or with IBM Watson, right? Or with Cotiviti, who have ginormous amounts of data, but not the health services research expertise. And not necessarily the policy lens to know what would be publicly most valuable given what they have.
Really, really great comments. Really, wow. And I think Peter just put some comments in the chat that are very consistent, Maya, with what you just described as well. And so I think we're starting to pull some themes here, Karen, if you're not noticing on some of this stuff. And actually, later on in the agenda, I'm going to try to summarize a couple of these that I'm picking up, but I'm certainly seeing a thread going through some of these comments here. I think our last comment before the break, and so everyone else who has comments after Chris is next, anyone else who has comments or feedback, you can certainly always, I think I'm gonna volunteer you, Karen, for people to be able to contact you directly, but also I'm gonna try to reserve some time if possible on the agenda at the end of towards the end of the meeting for just some open comment as well. But Chris, you're up before the break.
Great, thank you. And I will go very quickly in the interest of time. I appreciate all the comments that have just been made, and I agree with them. I think there's also a missing link for ARC in terms of remaining relevant. And that is, I think you need to build a true army of advocates for ARC. And I think part of how you do that is by what I'm going to call direct to consumer outreach. I don't know exactly what that looks like yet, but I think making ARC relevant to medical students and nursing students and graduate students in healthcare administration, anyone who wants to work in healthcare needs to know that they can go to ARC. The website's there. The website's hideous, by the way. There's lots of work to be done on the website. You can get, David Myers is laughing, you can get lost there and never get where you need to go. But I think that touching the lives of people who are already investing in what healthcare needs to be and saying, here's ARC is a missed opportunity. Every time I teach, people go, I didn't know that. I think by the same token and a little bit higher up the food chain, the opportunity to do some direct targeted outreach to CEOs, to administrators, to healthcare board members around snippets of what ARC has available. The ARC newsletters are great, but most senior leaders in healthcare organizations are not going to thumb through to figure out what they need. So I think just some more targeted communications and outreach. And last but not least, to patients and families. We're talking about patient engagement. As people age, they're growing up with the digital technologies. They're growing up with the understanding that data matters and that research is important. Ways to reach directly to consumers to say, this is the kind of work that's going on at the Agency for Healthcare Research and Quality. All of those that are all of us, that are funded, do that advocacy in the work that we do. But I think there's just a huge opportunity for some direct relationship building there. And I would, encourage ARC to think about how to do that.
So thank you, Christine. This is David. I was laughing because I had asked people to make us uncomfortable and tell us the truth, and you just modeled exactly that. We hear you. We're with you. Thank you for doing that. Edmondo, there was one more thing I wanted to do. If we move to the next slide, to help Karen continue this, okay, it's not there, to help Karen move this forward and continue the dialogue about stakeholder engagement, not about all of ARC. Many of the comments you gave are going to be Karen's plus the rest of us moving it forward. So this was incredibly rich, but focus specifically on our investments in the PCOR Trust Fund dollars in training, dissemination, and implementation. She came and said, I want more stakeholder engagement. She highlighted that. And one of the ways to do that legally is to have a SNAC, a subcommittee of the NAC that we could work with over time to get your input plus bring in other experts that you help us identify to give Karen the kind of feedback she needs. So I'm going to ask the indulgence of the NAC and Edmondo if that would be acceptable. Could we set up for you a subcommittee to have ongoing in-between meetings, public stakeholder engagement around these priorities.
Thank you, David. So the potential motion on the floor will be to form a subcommittee of the NAC specifically on PCOR that will be able to engage and hear from key stakeholders. That's a potential motion on the floor. Do I hear that motion?
So moved.
And a second.
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 Awesome. Anyone opposed to that motion? Hearing none, that passes by consensus.
Terrific. So now the NAC members get to think about, do you want to be a general NAC member? Do you want to be a general NAC member plus a measurement person or a PCOR trust fund thinking person? These are not all your choices, but we are, Jamie was where I saw Jamie's face there, but we certainly are interested in knowing who's interested in what. We won't be able to accommodate everybody necessarily, but we'd like to know who's interested. So we'll follow up with you afterwards.
And just to be clear, these subcommittees, they report to, and the reason why is because the subcommittees report to our advisory council. So you all always have a voice anyway. And so the idea is, while we want some of those folks, we also want, it's a way to get other outside folks and other key stakeholders that you all think it's important for us to hear from to actually have a formal way to contribute.
Very good. If that's the last piece of business before break, what we'll do is we'll take our break and we will, I'm just gonna give me 1 second to check the rest of the agenda. We will come back at 1 o'clock sharp.
Yep.
You got there? Okay, 1 o'clock sharp. Thank you.
Thank you.
All right. Right, Jamie, it's 1 o'clock. I said 1 o'clock sharp, so we're gonna move. Thanks for everyone for being on and coming back. Hope you had a chance to replenish and refresh during the break. At this time, we'll go ahead and, oh, great. Thanks, Patrick, for sharing that. At this time, we'll go ahead and bring Kamala Mistry on. So Kamala, if you, for those who don't know, is the Associate Director, the Office of Extramural Research Education at Priority Populations. Also a Senior Advisor for both Value Transformation as well as Child Health and Quality Improvement for ARC. Kamala's on to talk about health equity. I think, again, obviously a very timely topic, high priority for this administration, high priority for HHS. And I think it'll be great for NAC to get an update on this and see where things stand and where things are going to go. So Kamala, definitely looking forward to this presentation.
Great, thanks, Armando. So yes, we would like to engage you in helping us think about, oh, next slide, sorry. Next. I'll get used to this. Great. So yes, as Armando mentioned, this is an area of great interest, both at HHS and obviously something we're passionate about at ARC over many years. So we'd like to engage you in helping us think about ARC's goal in advancing health equity. I'm gonna quickly provide some context for this work, both at HHS and also at ARC. I'll update you on our health equity work group and also leave plenty of time for discussion and listening to get your inputs on our goals and priorities. So next slide. Great. I just wanted to start out with some current framing around equity. As many of you know, the current framing is very broad, but it's been very consistent from the current administration. It's really formulated around a comprehensive equity agenda that cuts across all aspects of work and priorities, and this includes COVID, access, health, and also climate, as David had mentioned. And so just to ground us, I've included here a definition of equity that was included in an executive order that's recently come out, and I'll give you an opportunity just to quickly peruse that. And as you can see, there's a strong focus here on social justice, on the role of historical and systemic inequities. The focus is really on seeing disparities and even social determinants of health, which we've talked a lot about today, through a broader goal of promoting equity. So it's really this idea, which you'll hear over and over again, around reaching the goal of opportunities for all. The definition also includes specific populations, and this is also meant to highlight inequities. I also included definitions of health equity and also health and healthcare disparities that we're using in grounding our work. And these align with the broader definition that was provided by the Biden administration in the EO that you'll see in the first bullet. The next slide. Great. I also wanted to review the some executive orders that really focus on equity and this wide effort to address equity across the federal sector. First, as Jeff alluded to earlier, there's been a large focus on equity within the work at HHS, particularly with regard to the COVID response. And so ensuring an equitable pandemic response recovery, this EO has really focused on highlighting that without tackling equity, the hardest hit communities will not be supported and helped. So equity is at the center of this. And so there's a need to clearly identify and eliminate health and also social inequity. So they've called both of those pieces out and really tried to think about how the two fit together within the EO and how this is really, these inequities have really resulted in disproportionately higher rates of exposure, illness, death in both underserved and minority populations. Additionally, a second EO, advancing healthcare equity and support for underserved communities through the federal government, was also put out. And this is really focused on the role of government in advancing equity. It's both inward facing, but also external facing, and asks us and others within the government to think broadly about how we define equity and systematically consider equity in the work that we do. This is including grants, in contracts, workplace culture, and to also ensure policies and procedures that are policies and procedures ours are not leading to further inequities. I'll talk a little bit more about this in our when I talk about the internal health equity work group in a few minutes. Next slide. Great. So we focus broadly in terms of the administration and HHS, but I also want to bring us back and ground us in the work that ARC has done in the past and our authorities in this area. So as you know, ARC has had a long history in this work of health disparities and health equity. The Public Health Service Act includes ARC authorities relevant for today's discussion on equity. This is requirements with respect to research, evaluation, demonstration projects for rural and inner city areas and priority populations. And it establishes a division of priority population and the agency's priority population inclusion policy, and a broad research, training, and dissemination authority for health disparities, including the QDR, the Quality and Disparities Report that Joel described. Of note, ARC's priority populations are defined as low-income populations, racial ethnic minorities, women, children and adolescents, elderly, and individuals with special healthcare needs. Additionally, I want to point out that the Affordable Care Act established offices of minority health and women's health in order to focus our efforts on these populations across HHS and also help us to coordinate our activities more broadly. Next slide. So I will shorten my discussion as many of these have been covered previously. And so I will focus on the first bullet, which is the SDOH, or Social Determinants of Health Integration and Analytics Grant, which internally we call the dashboard grants. These grants aim to identify and address social needs of disadvantaged populations using individual level and aggregate dashboards to guide clinicians and care managers in delivering whole person care. And so these grants really I think exemplify our focus in equity and really thinking about this work broadly, as I said, in its relation to disparities and also social determinants of health. The other items on this slide have been covered previously. The social determinants of health database, or the beta data that Joel described, you've already heard about, and I think Peter also alluded to that in his discussion or his reply. And also COVID-related hospitalizations. Joel did a great job of walking us through that data that from Pam's age cut brief. And also I wanted to point out the bias in algorithms, which I think that Jeff did a great job of describing first thing this morning. So that helps me move faster so we have more time to hear your thoughts. The next slide. Great. I wanted to talk a little bit about the health equity work group, which we've recently established here at ARC. Just in, kind of piggybacking off of what I noted earlier about the executive order, I wanted to note that we have three main areas of focus at this time. First is ensuring a culture of equity at ARC. A second area is policies and procedures to advance equity. And the third is really thinking about identifying scientific priorities to advance health equity. We've really established these as three work groups, and we're focused in these areas respectively, but we also have connections among these groups, and there's a lot of overlap actually, which makes us realize we're doing our work correctly, so that's great. We have a really committed team. These are teams that really pull from across ARC, so they're subject matter experts as well as tons of staff that have really, I think, pitched in, and it's a very committed team. I also want to highlight that there's, a lot of tension between our goal and being deliberate and making sure that we do this work thoughtfully and consistently and systematically. So we're taking time to think about all these pieces and each of them individually and then each of them together. I also want to say that we're going to focus on thinking about a coordinated communication plan, including things on the website, but even more broadly. And also thinking about an evaluation plan so we can really look and see if our work has had impact. So next slide. So Armando, I'm going to hand it back over to you, but I'll note that we want to hear from you. One thing that I just want to highlight before handing it over is just that really looking to understand from you where ARC can have the most impact. We've done this work, we continue to do this work, but we really want to think through with you how we can have the most impact. And some of that may mean going beyond our current competencies. We want to think with you about gaps. We want to think with you, as we did previously, about thinking about new stakeholders. I think, we talked about that in a different context, but where does that fit in here? And where are there opportunities to really grow? So with that, I'm going to hand it over. So thank you.
So really thank you for that comment. I think there's a lot of opportunity for rich discussion here. I'll run through the questions real quick, and then I'll start to take some comments coming through. I see Ram, I see you already. So quickly on the questions. Question one here. How should ARC focus its efforts to advance health equity given ARC's current core competencies? Then the second question is, okay, then what are the new competencies necessary to maximize impact in this area? And then third, who are the partners? Who are the stakeholders? Who needs to be engaged to move this along? So I think those are, obviously they're very interrelated questions and should be able to spark some conversation here. So I'll start to kind of observe who's jumping in. Again, Ram, you're first up.
Thank you, Chairman, and thank you for this opportunity again. Thank you for all the great work you guys do in ARC and health equity, and your framing this problem has been pretty good. I just want to make a couple of comments, because I'm somebody who's been involved in this for the last 20 years. I came to the conclusion that you can never ever get health equity in this country unless you have a social equity. So they have to go together as a part of it, because we have tried to improve health equity for last 20 years trying to do that, but social equity ultimately tied to health equity. So that is a fundamental thing. There is no health equity without social equity. The second thing we have to really be very careful is I strongly believe that we have really emphasized quality so much in the discussion last 30 years, but I also believe there is no quality without equity. So if you don't look at the quality measurements through the equity lens, we are getting a wrong picture all the time, because we have in aggregate, we improve the quality of people, but I can argue that most of the improvement came at the expense of vulnerable population. Their quality, their outcomes actually gone down but in the aggregate, we seem to do very well. So the measurements we had talked about a little bit, before, I strongly believe that the measurements should have an equity lens through that. Otherwise, we'll be looking at the things very, very differently. So I think finally the time has come, though we talk about health and human services at the federal department, at the division, at the cabinet level secretary, we have to integrate the social and human services data with the healthcare data. The problem we have right now is because there is so much of fragmentation of data. Healthcare monitors, I would say, sick care data. They're really not healthcare in this country, is really sick care data. Public health data is managed by public health departments. That's not necessarily different from healthcare systems. Then the health data, nobody manages, right, at the present time, because we don't know how many people are really healthy and what they do. And then the last part is really the social services data, which determines the food insecurity, the transportation data, the public service data, public safety data. All those things are really in some other place. So I think the time has come for us all bring them together in under one data set, on one measurement, able to do that. And that will be my plea to this group to say, the various committees are set up, all of them are phenomenal, and they will do a good job. I'm absolutely sure. But I think the time has come to integrate the social data with the health data so that we can have a holistic picture of the patient, not just his diabetes. We also have to get to know about where he lives and how much he do, because healthcare system, unfortunately, worked in the system for many, many years. I know more about your diabetes. I know less about who you are, and I know nothing about where you live and what you contend with each and every day. So we need to close that gap as a part of it. And one measurement at the end of the day, as we have gone into this over 20 years, I initially looked at everything through the racial equity lens, but the time has come when we have to start looking at it through the social data equity lens, because that is a better lens to look at it. What happened in the racial lens is really the end result of the social inequity which happened over a period of time. So I would rather have that incorporated into that. So at the end of the day, we have to really be, we really have to look at it through a different lens and different measurements, different way of doing things. I hope that we will have an opportunity, great opportunity to do this a very different way of doing that. So hopefully, thank you for this opportunity to talk to you about it. I think this will be a great opportunity to rewind the system and look at things a little differently than we have looked at in the last 50 years. Thank you.
Well, thank you. So so many good points there. One thought, because you think about it from a perspective of improving quality overall, but potentially at the risk of widening disparities, right? So that's one angle. The other way you could say that is if we did focus on those otherwise kind of underserved populations, like kind of a rising tide raises all boats type of thing. So you actually should still get to your ultimate kind of overall quality improvement as you focus on those populations. So I kind of observed a project along those lines where colon cancer screening was eliminated colon cancer screening disparities was eliminated within a state, and you saw the overall improvement across the whole population and not just the population that was focused on. So I think that's really important. Another really, I think, important point I want to pull out of this one is this idea of understanding, and I think this is very important from a research perspective, understanding individuals more holistically, right? And so I'm spot on, Ram, in terms of, looking at people as patients, right? When people are people, sometimes they're patients, most of the time they're not. And do we even understand who they are, and what are those metrics? What are those criteria? What are in order to understand who people are, and how does that help us, around these ideas around equity, around social determinants? So that's also an important point. And then another one I want to pull out of Ram's comment is what's the underlying challenge? What's the underlying influence on social determinants, right? So I mean, it's a comfortable term for us in health services research, social determinant. I think we're more comfortable with it right now. But one, what's the role of healthcare and what's the role of AHRQ, and how far do we go? How far down the line do we go? Do we start making comment about educational disparities? Do we start making comments about income disparities? Do we start making comments about food deserts? Like how far down that road do we start to go? And do we start to make or spend resources around addressing the underlying racism that and sexism that's core to driving the social determinants disparities, right? So like that, I mean, that how far down that road you go. So that I think all of those are going to be really important questions to address as you think through some of this. I thought Youngling had a question or comment.
Thank you. And I would just a comment. We talk about engage stakeholders to set up, identify scientific priority to advance care and also policy procedures to advance equity. I just wondering if ARC is thinking about to conduct some focus group to bring those minority group patients and families and people who are at a social and economic disadvantage in person to really listen to them, what their priority are from their perspective and experience. I think that would be very helpful to directly to hear from patients and families from those groups.
Yeah, I think that's a great point. We definitely have to hear from those perspectives. And it's often not captured in how we approach our data, our research, and our dissemination overall. Really good point. When I was looking at the chat, I saw that Susan had a point in here around the ABIM Foundation. Susan, do you want to jump on and talk about that?
Sorry, yes. The ABIM Foundation has had an initiative underway that's really picking up steam for the last couple of years. And they have basically accumulated a lot of information about different initiatives and programs that are being sponsored by different health systems and different healthcare organizations around the country as models of how we can work on these problems. And they also are giving out small grants and, excuse me, to organizations to do a better job. And they've engaged a very wide group of stakeholders, including many, many patients and patient organizations. And it might be interesting to have a conversation with them about what they're learning, what they're seeing, and where there might be some partnership opportunities. They also are, I know this, I'm on their board, but they also are actually in the field right now with NORC doing a national survey about how the public, what the public trusts in healthcare, what they don't, how COVID has affected that, and also what physicians trust and how do physicians feel about trust in different settings in the healthcare system. And I think that the data from that survey may be very, very interesting, at least I really hope it is, to help guide us where we need to do much more, what I think of as really deep work around structural racism and interpersonal racism.
Got it. Great. Thanks, Susan, for jumping on that. Gretchen, I think I saw you.
Yeah, hi. As I was thinking about this question of focusing efforts, depending on how much ARC thinks it knows already about how to advance health equity, and I'm not sure how far you feel that work has advanced, but at the point that you think you know enough to get the word out in the field, a model that comes to mind is the Institute for Healthcare Improvement, IHI, and the work that Don Berwick did when he was trying to address medical errors. And he engaged all of these hospitals, virtually everyone across the country. IHI put out a set of 6 interventions that they knew would work in order to, in that case, reduce deaths. And each of the interventions had an easy to read, free to download guide that named the intervention and defined it, gave the background on the science for why it would work and what the numbers were, And then most importantly, how to implement it. And if, you know, there's some beauty in that because it was a defined set of interventions. It was made available to everybody. You could sign on as an institution and participate. You could sign on as an organization that was not a provider institution and participate. And it was an all volunteer effort to implement this across the country, and it succeeded. So there's a lot of beauty in that, and I think IHI could be a partner in this potentially for how to do it. Obviously, you can either start with hospitals or not, and the bigger you make it, the more complex it is. But you know, wherever, I think it's a beautiful model to consider.
Good, Susan.
Yeah, just to jump in to support what Gretchen just said, and I put this in the chat. IHI, and the work has really been led by Kedar Mate, who's their new CEO, has developed pretty much what Gretchen was just describing around improving equity. And based on a lot of work they've done with health systems, both nationally and internationally, and they are also talking with the ABIM Foundation about how to, you know, sort of launch a more robust campaign, if you will. That's kind of how they think about doing these things. But I think it would be worth having a conversation with both organizations, because the other part of this is that everybody's got great ideas about what might work, but there's very little evaluation going on about what really does work and really does make a difference, where ARC could play, I think, a very valuable role.
Yeah, that's great. That's great stuff. But on the competencies, partnerships, all of that actually. So really good comments. One thing I was thinking about, and we discussed, if I discussed with the team before this meeting, so if you guys, some of you may have noticed that we, one, that ARC has a blog, and that we had submitted some of the NAC members submitted a blog, including Peter, who's on now, entry around telehealth not too long ago. This seems like potentially a good topic to blog about as well. Ram, you were first to jump in on questions on this, and you clearly have a lot of insight and passion around this topic. And not to volunteer you, but but if you would be interested in doing a blog on this, I think that may be one way to kind of continue and get this conversation going, continue to go out in the consciousness and really set and prime ARC's priorities in some ways and articulate those more broadly. I don't know if you have thoughts on that.
Thank you, sir. I will definitely do that. It will be an honor to do that. So I will be happy to take that on, and I'll send you that blog. That shouldn't be difficult.
And I don't know, Jimmy, on the process on this, but there may be if there's co-authors, you just popped it on there. So that well, I'm done talking because you just preempted my comments. Thank you. Any other thoughts, comments, questions on this really critical topic? I mean, there's clearly a lot more to go, but and again, I appreciate Kamala setting it up for us, and I think this is going to be an ongoing discussion topic, if for no other reason than because of how much of it's a priority for the current administration.
I think there's one more question from him.
Is there?
Dr. Yu.
Oh, there you go, Yana, go ahead.
Yeah, thank you. There's one of the questions at the bottom is, are there any opportunity to grow competency to maximize our impact? I think the COVID pandemic really helped us learn a lot of lessons on that. I hope the agency would pay a lot of attention on what the COVID pandemic have taught us about the health equity or the impact on people with a different racial and then different the background. And so That would help guide probably the agency what we need to focus on in terms of the public health, issues related.
Yeah, exactly. What are our learnings, and how do we translate those learnings moving forward? I think it's really important. And you're right. This pandemic, it's accelerated a lot of things. In the digital space, we saw a lot of it exposed a lot of disparities and a lot of ways. I don't know that I'm not sure if it created them versus more exposing them. But I think that is those learnings from that really should be codified and really should allow us to and accelerate moving forward in this space. So absolutely, good point.
Yeah, it's a tragic thing for the country, for lots of people, but it's a great opportunity for us to learn also from what I've missed and what need to improve. So.
Exactly. All right, so are we good? Did you get some good content there coming on this one?
I did. It was great. Thank you all very, very much.
Good.
More to come.
Awesome. All right, so thank you. Let me just double check and confirm public comment, Jamie. No. All right. So then we're going to move on, and now we're actually back on time to the chair's wrap. So here's what I want to do for this session. So there's a couple of themes that I wanted to pull in. One, I wanted to for those of you that just want to get in and get a you weren't able to get in and get a comments. I do want to open that up, but I'll start. And I'll just, and again, I'm just going to be kind of a little bit of a free fall. I'm not going to call on people necessarily, but for folks who really thought a point should have been kind of, they wanted to just get in there. We're going to spend some time doing that, but I'll start because I had a couple of thoughts, and so I'm going to use my chair's prerogative to share those thoughts. So one of the things I thought I heard today was actually around the influence of digital. Now, I'm biased. So I thought I heard it anyway, even with my bias, and I'll state my bias up front. I still thought I heard a theme around digital. And I thought there was a really rich discussion around that, right? But it's also very diverse within, what digital even means, right? We talked about virtual health and telehealth, and Yanli had some really good comments around that. We talked about new care paradigms, right? Maya really talked about some really changing care paradigms. We talked about point of care tools. Those are presented as well, and whether it's kind of clinical decision support, and some of the work and grants around that. We talked about the potential impact on disparities, both positive and negative, around digital, and that in the critical role that could play. And we even talked about advanced analytics. And AI and ML and those things, and all of that kind of loops into this, and is ARC going to be on the cutting edge of truly understanding that and really driving quality with these new paradigms and with these new tools and with these new tool sets, and things like things like advanced analytics that are now starting to take hold within the healthcare systems. So I think it was an important theme, and again, it overlaps with our last conversation in a lot of ways around social determinants of health, around equity, disparities, and so forth. But I think, given that I keep hearing that theme, and again, my brain's primed to look for it, so I'll put that out there. But as soon as I keep hearing that theme, I think continuing more work from ARC around those themes, around digital, around the impact of that, around virtual, around advanced analytics. I think that's the right place to be in a lot of ways, from my perspective. So that's what I heard. Rich discussion, really good conversation around that. I think I saw Ram first, so I'll let you jump in on this one.
Well, thank you, Chairman. And I just wanted to kind of, share my thoughts on the telemedicine and the virtual concept. I am excited that we are doing a lot of great things, but unfortunately, I'm also very, very concerned and scared, having been in New York and looked at what the virtual teaching has done to the New York City school children. it created a huge digital divide. The children who are already struggling through their classes did not have enough internet access, and they did not have a place where they could sit and be able to concentrate on the teacher's classes. A significant portion of the New York children who are in the public system happen to be homeless, and there is no way they can sit in a homeless shelter and be able to connect with them. Large portion of them are living in the public housing called NYCHA. They are not able to connect internet because they have no internet connection to do that. Actually, at the end of the year, we found that the people who are really disadvantaged, the digital divide, has suffered more than the people who are able to afford the computers and the internet and able to do that. I am concerned about the same thing will happen on the healthcare side. We have done so much technology on the provider side. We can able to do that, and we have all these great things available. But if you're not able to give a high-speed internet connection to the people in different parts of the country, people in the rural areas, people in other parts, then the whole telemedicine will actually create more disparities compared to, we already have disparity based on sex, ethnicity, gender, based on sexual preferences, sexual orientation, and lack of immigration status, lack of insurance status. We will be adding one more disparity group saying lack of digital access. So I just wanted to be, keep the radar up so that we don't create more vulnerable population as our desire to move this forward to a great extent. I'm sorry to be a kind of, a negative on this, but I just want to have my views expressed. Thank you, sir.
No, I love it. I think it's spot on, and we have to keep it in our consciousness in the front, not in the back of our mind, in the front as we think about this. I think what was presented earlier around disparities, and I think it was racial ethnic disparities in AI algorithms, right? I mean that's a similar concept where wow, these AI tools would really be great, except they might actually widen disparities, not improve on disparities. I think you're saying something similar. It's a digital divide that we potentially could create or exacerbate if we're not very conscious about and very deliberate about how we approach this. So I think it's a very timely and very important comment to make. So thanks for that, Rob. Other thoughts? This is kind of wide open here, but other thoughts. Go ahead, Patrick.
Yeah, I just wanted to build on some of the comments that Mai and others have made over the last couple of hours. There's a gorilla in the room that nobody's explicitly mentioned, but it has to do with the fact that the Medicare hospital insurance, the Part A trust fund, is rapidly going insolvent. And I think the latest projections, incorporating the impact of COVID, is that it may go insolvent as early as 2024, possibly 2026, which is even the best case 2 to 3 years earlier than was projected after the ACA was passed. From having worked in the healthcare industry for 30 years, we see that healthcare providers are tremendously resourceful in finding new and creative and innovative ways to spend other people's money. And so I worry, about the value equation with respect to some of the telemedicine, telehealth interventions that we've talked about. It's wonderful that CMS has had the flexibility to change the way that care is delivered and to continue to push money out to ensure that Medicare beneficiaries have access to care. But the bill is coming due. And so now we really have to bring value back into the discussion and think about, I know this is not AHRQ's primary remit, but clearly value is inextricably linked to quality and safety. So how do we integrate those research agendas so that as we evaluate these new interventions, these new payment models, these new approaches to delivering care, we assess not just what the impact is on safety and on traditional patient outcomes and equity, but also do they add value? And how does this tie in with the impending troubles that are affecting the Medicare program, which is so important for the American people?
Yeah, no, that's great. I really appreciate that. And I like to think about that. Value is a great word, especially if you define it. Because I mean, in some cases, it's value from whose perspective, right? You know, societal perspective, from the payer's perspective, from the individual patient's perspective. But I love the richness of that concept and really using that as a driver. So that's spot on. A great comment. What I'd like to do, and I saw you, Peter. What I'd like to do is, if David, if you don't mind, I appreciated you giving us some time back in terms of kind of skipping over the communicating the value of health system research. But if you don't mind, just taking a couple minutes, to open that topic, just so people can kind of get a feel for where you're going with that, and then we can kind of go from there.
I appreciate that, and I'm very happy to do that. Thank you, everyone. And I think, Patrick, you teed this up perfectly. So how do we communicate concepts like value? That brings us to the topic at the beginning, or that was earlier on our agenda. In 2020, early 2020, AHRQ published a report, an independent evaluation conducted by the RAND Corporation on the role of health services research across HHS and the VA, and how it was being done, how it was being coordinated, was it having an impact, and how it could have greater impact in the future. And they also did a report at the same time on the role of primary care research and AHRQ's role in that, and the department and the VA. And their main conclusion was that health services research, as all of you, I think, believe, has enormous impact, has enormous value to the system, but it's underfunded. And as we dug into this, we realized a perpetual problem for AHRQ is communicating the value of health services research. And I can imagine in a world moving forward where costs in general and spending in general and great pressure to produce value, that if we are not able to communicate about why health services, what it is and why it's important, it could potentially be squeezed out at the exact moment when it might be more important than ever. And so teeing up for you, the NAC, to help advise AHRQ from your differing perspectives, how can AHRQ and how can the field of health services research better communicate what it is and why people should care, how it brings value? And I think there are many ways to do this. But in our prep call for the meeting, Dr. Robinson pointed out that sometimes he's heard me say, and AHRQ say, health systems research, and other times the field calls itself health services research. Both have the nice acronym HSR. Why were we doing that? And the history there was that when our legislative governmental affairs director, Boyce Janeski, would bring the director of AHRQ to meet with Hill staff and educate them and talk about health services research, they'd glaze over and go off on very bizarre tangents of not understanding what we meant by health services. They got lost in the name. And so we attempted to help that by calling it health systems research. It actually works somewhat because that's what AHRQ wants to be known for, thinking about the system as a whole, the delivery care system. We know other people in the outside world have switched to using words like delivery systems research is, again, a way to capture people's imagination. But while we made progress with one audience, what we discovered, as Dr. Robinson pointed out, that the very health services researchers who we partner with didn't know what we were talking about and got confused, and we were causing a new problem. So I don't think we figured this out, and we wanted to bring it up to the NAC now for two really important reasons. One, the report itself, we are going to continue moving forward with its recommendations on increasing the impact of health services research. And we want to understand your ideas about how to make that happen. And two, at this moment of transition with new Congress people, with their new staff, with people moving around, and we're going to have the opportunity to educate them. We have a new department. We have new department leadership. By the way, the vote did happen. The Senate confirmed Secretary Becerra. He will be sworn in the morning. So great news there for moving forward. but he comes from a different world too. The language of health services research is not going to be natural to him. So we're going to have to communicate this inside the department, with our stakeholders, with health systems and health professionals themselves, and with Congress. And so your advice on the best ways to communicate what is health services research and what is its value, so ARC can continue to have a great impact. We'd love that. If we don't have time today, we'll follow up with the NAC members and engage you in a dialogue, but sounds like people are already giving us ideas. So thank you. And thanks for getting me back on the agenda, Dr. Robinson.
Thank you, David. I really appreciate that. And we can certainly follow up on that. Certainly connect with David or Jamie on some of those comments. I think it's such an interesting topic, and especially when you set it up, it probably does deserve a little chunk of time at some point. So it'd be nice if we can kind of get to it. But certainly in the interim, while report is kind of still being worked on, and we're still having some of these comments, and Jamie's dropping some links in there for background information as well. We want to keep pushing forward. One thing I want to get to Peter, but I do want to make sure I don't forget to remind folks that it is Patient Safety Awareness Week, and so just I want to just and I know ARC's got some stuff on that. A lot of other organizations are looking at that as well. But just a reminder, keep in mind that it is Patient Safety Awareness Week this week. Peter, you're up.
Great. Well, just wonderful comments. I really just agree with what everybody's been saying, and maybe a comment I was going to make, and I think it dovetails nicely with David's comments and questions there. In addition to the particular focus on equity and the needed focus on that and the AI agenda, the increasing focus, and we did mention it a few times, but I think growing importance of the focus on patients or people, frankly, and the changes that we anticipate coming in the coming years with the 21st Century Cures Act and how that all sort of makes its way into operations. There's another kind of elephant that I think dovetails with all this, and it probably does speak to some extent to the HSR question, which is, and it's come up in multiple conversations I've been having recently, which is this intersection between the academy, if you will, and the operational component of what we do in HSR. And as someone who is working day in, day out to try to really operationalize learning health systems and work at that intersection between academics and operations, it's a real challenge. And it's a challenge where we continue to face headwinds, in part because of, I think, some of what you've alluded to, David, which is this sort of divide operationally. Sometimes our language isn't quite right, and it's often, oh, those are the ivory tower propeller heads trying to come in here and just sort of use the environment for their studies, as opposed to, we're already doing quality and we know how to do that on the operational side, and we're sort of talking past each other, I think, more often than not, and we can't afford it. We can't afford it given the importance of the work. We can't afford it just monetarily to sort of be doing these things in parallel, and it's going to slow us down. And I think there's a really important role for ARC to play as a leader in terms of helping us identify and expand models where we really have this collaboration between the academic HSR types and the operational HSR types, whatever the S stands for, to be able to actually do this work together.
Yeah, I think that's really important points. And it's that operationalization. I mean, we saw some presentations around that, whether it was in the nursing home situation or something that where it's really that bridge between the academics and the operationalizing. And as you know, because Peter, you do this every day, it's hard work.
Yeah,
it's
very
really hard. But it's so critical, and I think keeping an eye on that, and even to the point around some of the tools that IHI kind of laid out. Even if we can give some tools around what it might mean, to actually bridge to be on that bridge and get it across that bridge is maybe something to keep in mind as well. So outstanding points. I think at this point, I think we're going to go ahead and wrap up. So along those lines, I do want to thank
Armando. I think Greg had sorry.
Oh, I'm sorry. Did I miss someone?
I think there's one question. Greg Alexander had
Oh, go ahead, Greg. Sorry, I'm sorry, Mr.
Yeah, this won't take very long, but I also appreciate the comments and sort of the vision that AHRQ is laying out. And but I think I wanted to just throw out some ideas about what to watch for, especially in the space of long-term care, which, like I said, is where I come from and sort of my experience in on this panel. The Senate Finance Committee late last year put out, Senator Casey from Pennsylvania put out actually introduced a new act called the Nursing Home Modernization Act. And that act is very important if it gets through. It's very important in evaluating quality in health systems, especially related to long-term care, and looking at high and low performers. And it relates very much to the comments I made earlier about the rating systems and nursing home compare and other ways they're measuring quality in that space. And I think the ARC has a lot of history, and we have a big grant mechanism out there in R18 that relates to long-term care that I think probably research findings from that work could really inform those acts, especially cutting edge research that will help them understand how to measure quality better and how it's impacted by certain types of interventions and initiatives. Then there's also these kinds of initiatives are becoming more evident. There's recently, just today, JAMDA, the Journal for the American Medical Directors Association, the editors have put out a call for articles on reimagining long-term care due July of this year. And the context of these things is that the system is changing. And I think ARC has a great vision for that and could have a great vision for that over the next 10 years. And simultaneously, there's another initiative that I'm part of with the National Academy of Medicine called the Quality of Care in Nursing Homes that has begun. And that committee will be making recommendations about the future of care in long-term care space, specifically related to nursing homes. And I think ARC has a great role to play in shaping that vision based on the work you've done, and expressing that and getting that out through your dissemination processes would really help formulate these ideas as they're being initiated. Thank you.
Thanks, Greg. I appreciate your comments as well. Any other comments? All right, I think we're good. I don't see anything on chat new. Okay. So with that, if I'm not jumping the gun again this time, I want to thank the folks who presented, Jeff, Arlene, Joel, David, of course, Karen, Kamala, for all their presentations. Really wonderful content, really wonderful discussion. Always want to thank Jamie, as well as the AHRQ staff who were on meeting on Zoom. We had, we stayed over 100 people on the, and I think at height it was around 160 people were on the call. So really good engagement and participation there. The next NAC meeting is July 14th, 2021. And it will be a virtual meeting, right, Jamie? So that it will be another virtual meeting. I'm still holding out hope for a physical meeting in November. It's not my call, but I'm still holding out hope for a physical meeting in November. I miss walking across the entryway there to head over to lunch in the cafeteria. So, but I'd love to get to see you all again. But it will be a virtual meeting in July. And I think, let me just check the last chat to make sure I'm not missing anything. No, I think we're good. So with that, I will entertain a motion to adjourn.
Well, wait, before we do that, we have to thank our chair. He just set a very, very high bar for how well he's going to run meetings for on time and engaging everybody. So thank you so much, Armando, for taking this on and for a great meeting.
Okay, thank you. Thank you. Now I will entertain to adjourn.
I think I saw first from Peter.
All right, a second.
Thank you.
And a second. It's moved and seconded without any objections. That motion will pass and we are adjourned. Thank you all. See you again soon.
Be well,
Bye-bye.
everybody. Stay in touch.
Bye.
Bye.